And Magdi, if I can ask you to start with our first talk, please. Thank you so much.
Thank you, and I would like to thank Fahim actually for doing a fantastic organization effects to keep these educational activities very well run. So he asked me to make a quick chat, so I picked up a topic which we all possibly suffer from. So it is back pain. I'll try to make it simple, so at least step by step tell you what to do and how we can help if anything goes wrong. So basically, when we talk about pain at doctors, we say it's either to do from tissue problems, so we call that nociceptive pain, or neuropathic pain, damage or trauma or dysfunction of the nerves. So that's simple, but it's a useful classification. So the nociceptive, like from the muscle, from the joints, usually the patient feels the pain as a throbbing, aching, or he can simply feel some stiffness. But if the pain is coming through the nerves, the patient usually feel a different sensation, which is usually unique and help a lot in the diagnosis and the treatment. The patient use shooting pain, electric shock, burning, numbness, or tingling sensation. So you've got two types, basically two mechanisms. But in fact, in most of the cases, go backward. We get mixture. Most of the patient we get both types. We get tissue damage or tissue dysfunction and also nerve dysfunction, nerve pain. So for you, it's pain, it hurts. So what we can do for that? The commonest problem in the back is the disc bulge, herniated disc causing low back pain, and radicular pain, which is, we call it sciatica, pain going through the sciatic nerve. So that's an example how the vertebra is, and this is the disc in between. Basically, it's two distinct structures. The outside is very strong, called annulus fibrosus, and the inner side should be jelly thing. That's what allow us to move in different direction. Fantastic joint. So when there's a tear or cut of the outside, the content of the inside, which is the gel, gets out. So if he catches a nerve, that's just here magnification. So here is the disc, and here is the nerve. So you get first the two process. You get the activation, which is the inflammation, that's a nociceptive pain. And once you irritate the nerve, you get the neuropathic pain, and the pain is spread down the distribution of that nerve. Why we talk about it today? Because it's very common. Every one of us must have had at least one or two attacks of back pain. So it's very, very common, actually. All of us suffer from it. But although it's very common, usually it recovers by itself within a few weeks. It's only around 5% usually get it for longer time. More than 3 months, we call it chronic pain. But in 5-10%, the back pain is associated with leg pain, the sciatic part, which really cause more problem. So what to do? I try to make it the simple things, and I use the 3L approach. Listen, look, locate. Listen, basically, that's the history, so we have to listen carefully to every details, because the more detailed the history, the better the diagnosis. Look, that's examination, that's what we look specifically for what's wrong. And then locate, we correlate all signs and symptoms together to make a diagnosis. And one, we know where the problem is, or what's the mechanism of the problem is, now we can treat it properly. So effective treatment starts by effective diagnosis. Without good diagnosis, you had no chance at all. So the history, listen, it's a very long story, but basically the most important things for me is time. GP kindly do their best, but in 5-10 minutes you won't be able to take a full history of back pain. That's why in any pain clinic usually give at least 45 minutes. I allow 1 hour for the patients. So we take the personal history, but also take the history of pain, where it is, where it goes to, how it started, how long, is it getting better or worse, how do you feel the patient. And this is very important, very simple, and a lot of people actually forget to do it, to say, am I getting better or worse? Just basically measure the pain. So this is VAS, called Visual Analog Scale, which basically the patient give himself a number out of 10. 0 means no pain and 10 is the worst. Then you measure that on average and the least pain and the worst pain. So once you know your average pain at the same point of the day, morning or evening or lunchtime, you know yourself if you're getting better or worse, because we all tend to forget. So severity is very important. Then we need to know what makes it better and what makes it worse. And the most important things for you is the red flags, which is bad signs. Basically, we call it coda equina syndrome, when there is a very bad large disc pressing the spinal cord, affecting the function. Which, if you get one of these, you need to go emergency to the hospital. Usually unable to walk, leg weakness, perineal sensation, you don't feel it, or you lose control of your urine or stool. Any of these things is bad enough. Without any hesitation, you have to go to the hospital. They'll be definitely doing an emergency MRI scan for you and then check, do you need surgery or not, which is the most important things to look for, the red flag signs. I'm sorry for the skewy things because I think the transport of the lecture from different system give a bit different picture, but part of the history, we take what treatment the patient had and how the pain itself affect the patient, and I call it the 3S syndrome. The effect on the sleep, and then the sadness, which basically the effect on the mood. Most of us, when we get pain, we don't work, we don't sleep, so we get frustrated, we get depressed. And also the suffering, which is the lack of activity. Your quality of life quickly get worse and it get bad. And then we review the other system, any other treatment, and what medication. Not only painkillers, but also some drugs like anticoagulants, because it affects the way we treat the patients. But it takes much longer time than this. I give the patient a simple thing called body map. It's a brief pain inventory which I invented more than 20 years ago after a visit to South Carolina hospital. I was working in the States. So like the patient give a back pain and a specific marking going to the big toe. If that's the case, clinically I know that will be like a disc bulge pressing on lumbar 5 nerve root. So sometimes useful, but sometimes we get description like this from the patient, which doesn't tell you exactly any clues. That's why it's important to complete the examination. So we basically look at the painful area and correlate it with other area, and then we examine mainly for the neurology, the nervous system, sensation, motor, and reflexes. Then for the back, we do a lot of specific tests, looking for the nerve stretch. It's called straight leg raising test. Some tests affect the function of the hip or the sacroiliac joint, called Patrick test. So when the patient say I've got a leg pain or sciatica, it's not a disease. We have to find the cause of that. Then we can make a plan to treat that specific cause or causes. So to make a diagnosis, this is the body maps. Every, subhanAllah, Allah creates us in a fantastic way. Every nerve going for a specific area. Neck and chest, and also the back, that's why we talk about it. So we know exactly clinically, but when we test as well, we look for the abnormalities. If still the picture is not clear, we may have to do some investigation like X-ray, usually if suspect fracture, MRI scan if you suspect any nerve problem or a disc problem, CT if we suspect mainly disease, bone disease, and then the bone scan is for metabolic disorders or a tumor. Some other tests is done, but more specific. A very important point when the patient comes to us, not only with the back or back and leg, they've got a lot of comorbidity, which sometimes more important than the condition. We have to consider that, assess it, and help as well. So look at this from a lot of research, what patients with back pain have. More than half of them has difficulty in sleep, lack of energy, drowsiness, difficulty in concentration, depression, anxiety, poor appetite. All that's a problem. And some people say, I've been like this for a long time, but that's not normal. It has to be properly assessed and properly treated. So we always, for the look of the body, not just the pain, we look of all of you to see what's wrong. This is a picture of me a few years ago with the big pyramid of Giza in Cairo. So once we got the history, the examination, and the investigation, we should be able to make a clear and better diagnosis. So we need to know where the problem and what's wrong there, either in the bone, so the vertebra, or in the disc, like a tear or bulge, or in the nerves, disc herniation or canal stenosis, or in the joint, the commonest one, beside the disc, in the facet joint or the sacroiliac joint, or in the muscles. In a lot of conditions, there's many factors in one case. I've been doing that job now for 30 years as a consultant. I've never seen one cause. There's always multiple causes, but the commonest one was one cause when there's a fracture of the vertebra from osteoporosis or cancer metastasis. Otherwise, the rest sometimes have multiple factors. So when we treat this patient, we have two main aims basically. Not only reducing the pain, but also improving the function, which is basically the quality of life. Not just say your pain, make it better, but we try to make all your life better. How we do that? So I made it as simple as possible. First, we explain and I show the patient what's wrong, what you could do, how can you help yourself. And then we use a drug, either painkiller, antidepressant. But when we do prescribe medication or advice on them, I consider this step: S for safety, T for tolerability, because a lot of patients have comorbidity, effectiveness, how effective this drug is, and then the P for price, sometimes important for the patient. We'll be finishing in a couple of minutes. And then the patient preference, which is very important. Then if it doesn't work with this, we use a lot of non-medication like exercise, physiotherapy, acupuncture, TENS, osteopathy, cognitive behavioral therapy, or a pain management program. And if all that doesn't work, now that's where I do. That's injection. I'm a specialist called interventionist, so we do needle approach, intervention to help the back pain and the sciatica. Why we do injections? First, to diagnose the cause of the pain, like we inject around the muscle to see if the muscle the cause. We inject around the joint to see if the joint the cause of the pain. Prognostic, like sometimes some surgeon asked me to do a selective nerve root block, to see if you block that specific nerve, the patient's pain will go away. So if he do the surgery and take the disc away, the patient have a long term. Or get better. So usually if the patient had pain for more than 3 months, we aim not for cure. Usually we aim for pain control, which means more than 50% improvement. But if you get the patient early for a fracture or a disc bulge, we definitely achieve pain relief as well, cure forever. So what to inject? Sometimes we inject nothing, and that's called a dry needle effect, like acupuncture. I don't do that, other people does it. And then we inject local anesthetic or steroid for the muscle of the joint or around the nerves, Botox for the muscle spasm. And if there's a fracture, we even inject cement, like the cement they use for hips and knees, to fix a fracture, called vertebroplasty. And recently, I've been using for the last 4 years something very nice, actually called platelet-rich plasma, coming from the patient's blood, or stem cell as well, from the bone marrow or the fatty tissue, to regenerate the tissue, not just to heal it, but to get it back to normal. And there's very good evidence around it at the moment. So I'm really just going to mention a few examples. This is a muscle called piriformis muscle. So this is the anatomy, but this, when you put the needle in, you see exactly the dye in the round area, so we can really diagnose and treat. This is an example of a sacroiliac joint. We see the needle specifically on the right point, and we can kill the nerves for that, called innervation, if it's effective. This is the spine, but it's a turned, or the x-ray is turned around it, to get a special structure to see the facet joints, again with high accuracy, to diagnose, block, and if it's effective. And then the joint, hip, or knee, or the ankle, either inject steroid or lubricant, or recently the regenerative medicine using the PRP or the stem cell. At 10 to, again around the nerves, this has just come from the bottom caudal, this has come from transforaminal, this has come again from lateral approach. See, this is a typical nerve, so we can really have very specific treatment, only highly successful, no or minimal side effects for the patients. And this is an example when the patient has a fracture and we put cement in it to fix it. It's called vertebroplasty. So that's it. Thank you. I hope you enjoyed it, and I'm free for any question. If there's not enough time for a question, I will stay outside for 1 hour for free consultation. Yes?
Yeah. I'm here to ask questions all the time.
One question, because we're running over.
I have a question.
Okay, two. You're a popular guy. Two. Who was first?
This lady was first, actually.
Okay.
Yeah, I fractured my arm this year, and I'm having pins and needles in my fingers, waking me up in the evening during the night, and I'm just wondering what I can do for the pins and needles in my fingers.
Yeah, exactly. The next speaker is going to be who you need to speak to, but he can give you a bit of an intro. He runs on quite nicely. That's why I did it this order.
Yeah, it's not uncommon actually. Either from the trauma or from the surgery, whatever they did for you, they may have some sort of nerve trauma or dysfunction. So what to do for that? Usually there's a specific, simple topical things, either non-steroids or something called Versatis, lignocaine 5%, that can help a lot that local pain. If not, you use systemic like gabapentin, pregabalin, that usually settle, or amitriptyline, tricyclic antidepressant, that also can help a lot that nerve pain. But obviously it's difficult to give better advice without proper assessment examination. It's just a simple advice. I hope that's useful.
That's very useful, yeah. Sorry, one more question, then we need to go to the next speaker. Everyone will get a chance, but it's just a packed schedule, please.
Yeah, it's basically about rheumatology, but it's linked because all of a sudden I'm getting a lot of back pain, and I'm wondering, is it linked to rheumatology or arthritis?
Well, there's a rheumatology speaker, so let's leave it for that one.
Yeah,
Okay, we'll change, yeah. I think all of the range of specialists are here, so I think we'll take it then. Is that okay?
Assessment. Once you get assessment, we can make a diagnosis, then we can treat.
Can we get a round of applause, please?
Thank you very much, Fahim, for the invitation, and thank you very much to all of you for attending. So I'm an orthopedic surgeon, so just as Fahim said, so orthopedic surgeons have two roles. So we fix broken bones, like yours, but we also treat routine problems, and my specialty is hand and wrist problems. So I saw a gentleman in clinic a couple of weeks ago, so 70-odd-year-old gentleman who worked in heavy work for the whole of his life. So working in the railways, a lot of heavy lifting. And he'd gone through his entire life with his hands being his most, precious elements, just because he could lift so heavily. He was very strong. And he came to see me in clinic because he was in that much pain that he couldn't even now take a cap off a milk bottle, where previously this man was lifting loads that he'd never, think twice about. And the question he asked me in clinic was, why are my hands hurting? And that's what I'm going to try and answer here. Hands hurt for a number of reasons, so there isn't any one simple reason why you get pain in your hands. But there's two elements to answering this question. The first is, of course, what you use your hands for, and the second is what is the pain telling you. We know that we use our hands for a number of things. We use them to eat and drink, look after ourselves. It's a way that we connect to the rest of the world. So you always show a connection to your loved ones. You shake hands with people. It's a social way of trying to interact with people. It's a way of, I guess, building your life, and your hands age with the rest of your body. So your hands, I guess, in essence, tell the story of your life. But your hands also connect you to your own body as well. So when your hand is painful, it means that your body is trying to tell you something. And your body's normally trying to tell you one of three things. So the pain is either your body telling you that you're doing too much, it's telling that you're doing something different, or something has changed, or that there's a problem somewhere else in your body and the symptoms in your hand are now showing you that something's gone wrong. So to take that in turn, so the first thing, of course, is that if you are, say, for example, a 15-year-old who plays the piano, and you've gone from training twice a week to 4 hours a day, well, clearly you're doing too much. So your hands are painful because you're doing more than you should. So if it's someone who's done, say, DIY for the first time in 20 years and you've sanded an entire room, well, your hands are going to be sore because you've done too much. Your hands are not conditioned for that sort of thing, and that's the reason why they become painful. The second issue is when, say, for example, if you've changed something, so you're at work, you've bought a new keyboard or a laptop which is stiffer, you're using instruments at work which you haven't used before, you've changed something as simple as your mattress or your washing powder, that can cause pain in your hands. So it could be something as simple as that. The other part of that is that something might have changed. So arthritis doesn't develop overnight. So things, there are certain conditions in the hands that you will not just get all of a sudden, but it will be very much, you've gone from having no pain to a lot of pain all of a sudden. It could well be just an injury that sets that off. It could be that your wear and tear in your joints got to a point now where it's starting to become a problem. And the third thing, of course, that the pain is telling you is that there could be a problem somewhere else. So say, for example, if you've got diabetes, if your diabetic control is not good, that can often present with pain in your hands. So pins and needles and... Sorry? I can't hear what you're saying. So arthritis. So there's another speaker who's talking about rheumatoid arthritis, so I'll let her cover that, but I will touch on this shortly. So back pain, you have to see Dr. Aglan for, but you can get in touch with him. So I guess in a nutshell, there's a lot of reasons why you can get pain in your hands. So pain is either telling you that something you're doing too much, something has changed, or that there's a problem somewhere else. Thankfully, the vast majority of things that cause pain in your hands can be treated and get rid of the pain altogether. The treatment depends very much on what the issue is, but more often than not, there's a solution for it, and most of them are not surgical. I guess there are some things that we treat with surgery, but I guess that's where I come in. So I was just going to open it up now to give you an option. So does anyone have any hand pain? So you mentioned that you've got hand pain. So go on. So you describe your symptoms to me.
Yeah. In this year I was on holiday and I fell down an unlit stairwell and I fractured my arm, and ever since then I've had pins and needles in the fingers.
Was that immediately at the time of the operation, of the injury?
I was okay before.
Yeah.
But I'd had an MRI scan and the consultant thinks it's coming from my neck, but I think it's coming from...
So yeah, it could well be. So I am around for about an hour or so afterwards. So if you'd like to come and speak to me and I can have a look at your hand. But there's a number of reasons why you can get pins and needles in your hands, and that's one of the most common things I treat. So it's something called carpal tunnel syndrome. I don't know if anyone's ever had it or any experience of it. But it's normally where you get a trapped nerve in your wrist. So if you imagine your body has two sets of, I guess we often confuse things like nerves and veins. So veins and arteries are like the plumbing of your body. So they're what send the blood around. The nerves are like the electrics, I guess you could say. So that's where the signal sends the brains to your hand. So if your nerve becomes trapped, you will then start getting pins and needles or a painful type of pain that wakes you up at night. This is the sort of thing that you often find happens with something like that. So most patients will often complain of the hand going dead or a pins and needles or burning feeling in the hand. You've got to shake it off to get it back. You might wake up and your hands take a while before you can start using them. Some people complain when you drive or reading a book. These sort of things that often do that. And that's because the tunnel that your nerve runs in has tightened up. So instead of being a nice open space that the nerve can run through, if you've got, say, for example, arthritis or swelling in your body, if you've got your tendons become inflamed, all of these things will tighten up that space. And then the nerve starts becoming painful. In the early stages, just simple things like wearing a splint at night where you just keep your wrist straight, that can help. Anti-inflammatory gels can help. Steroid injections in some cases will get rid of the symptoms. And if all that doesn't work, then there's a sort of a 10-minute operation that you can do to get rid of the symptoms altogether. Okay. I'm conscious that we're short of time, but if there's any specific questions, I can answer them. If not, I'm sat at the back for about an hour. Quite happy to have a look at your hands if you want. Any questions? So, no?
Are you sure this is an exceptional opportunity? Anyone got any issues with hands, either carpal tunnel, ulnar nerve, cubital tunnel syndrome? There's so many that are out there. Trigger finger. Would you mind just saying a couple of minutes on trigger finger?
Yeah, sure. So trigger finger is where it's a bit of a strange name. You assume that it's something that gunslingers from the Westerns do get, but this is where your fingers stick. Normally first thing in the morning you wake up and your finger's stuck and you've got to straighten it out, or your finger will click when you bend it and it just opens up quite slowly. And it's normally where your tendons, which let you bend your fingers, get trapped in the tunnel that they run in. So if you imagine each finger has two tendons and there's a tunnel that runs between here and here, and the entrance to that has tightened up. So now when you bend or straighten your fingers, they just can't pass in and out quite so quickly. And that's why you get the clicking or the sticking. Most of the times, if you get that early, that can be treated without an operation. Just a simple splint at night or anti-inflammatory gels will get rid of the problem. Steroid injections will cure it in 70%. And if that doesn't work, well, then there's a fairly simple operation for that too. It's something that takes probably less than 10 minutes to do, and it means that it'll be completely cured. Okay.
That was more for me, I think. Thank you. Thank you so much. Please, if you need a... Yeah, there's a question at the back. What sort of exercises are good for your hands was the question. Just repeating it for people who didn't hear that.
So, I guess the simple answer is that any exercise for your hand is good. But the main things that are, I guess, good in some circumstances are not necessarily good with others. But the question generally relates to things like arthritis. So the important thing is that you keep the joint supple. And it depends on which type of arthritis that you have. So say, for example, you've got a rheumatoid or an inflammatory arthritis, then often using your hand too much when it's inflamed will increase the pain. But you need to use the opportunities where the hands aren't quite so inflamed, that you try and keep your joint supple, keep them moving as much as you can. If it's painful to use them with the one hand, you gently use the other hand to try and keep the joints flexible. But yeah, if it's something like rheumatoid arthritis, then you avoid trying to move them too much when it's inflamed. But I'm sure the next speaker will touch on that.
Thank you, Dr. Shiku, for having me today. So more hands and more pain to come, but mine is completely opposite to Mr. Eunice's and Dr. Aglan. This is a different pain, okay? So when we talk about rheumatoid arthritis, we are going back by centuries. So in early 1800, French physician Augustin Landry-Bouvet felt that this type of arthritis wasn't similar to the typical gout. And another 50 years later, it was Sir Garrett who felt that the fluid of these patients don't have crystals, so it must be quite different. And it wasn't until 1890 when his son gave it the formal name rheumatoid arthritis. So what is rheumatoid arthritis? It's a chronic, autoimmune, inflammatory, systemic, symmetrical polyarthropathy of unknown origin. So let me briefly go by with bits one by one. So chronic means it's not just a once-off pain. Autoimmune, our immunities are like an army, our defense system, but instead of defending us, it attacks the own cells, and that's how autoimmune conditions come into origin. Can you hear me now? Yeah. Okay. It's systemic, so it's not just the joints, it's well beyond the joints. It's symmetrical, that means equally on both sides. And polyarthropathy, so it's not just one joint, it's more than one joint. When we say unknown etiology, that means it happens in genetically, immunologically susceptible individuals with certain environmental triggers causing it. It's quite common, about 1.5 to 3.6 per 10,000 population in the UK, 208 globally, and it's more prevalent in women, so it's about 4-fold increase in women as compared to men. It's not a disease of the elderly, it presents between the 3rd and 5th decades. Dr. Shiku, do you want to keep the slides moving? If you go to slideshow. So what are the early signs? First thing is stiffness in the morning, early morning stiffness lasting for more than an hour, persistent, soft, squishy swelling in the small joints of the hands, and it's been there for more than 6 weeks. When I say persistent, soft, squishy, so we're not talking about bony hard swelling, we're not talking about transient swelling, we are talking about persistent, soft, squishy swelling in the joints. When we actually look at the joints, we can see they're quite inflamed. So if you look at the middle joint of the finger, you could see it's quite inflamed. And next, please. I won't go into the classification criteria, but there are 4 things which we look at. The number of joints, the type of joints, the level of inflammation in the blood, presence of certain antibodies, and the duration. So the smaller the joint is, the heavier the weight it carries. So if there's more than 3 to 4 small joints involved, the high score is given. Next, please. Then we look in the blood for antibodies. The common one which we use is called rheumatoid factor, and the other one is ACPA. So I just want to clear the misnomer. You might hear that the blood test for rheumatoid arthritis is positive, but that on its own doesn't mean you have the disease. It needs to be positive with a high titer, and people who have a positive antibody are at increased risk of getting other organs involved. Next, please. Then we look at the level of inflammation in the blood and the duration. Next, please. So if we get a score of more than 6, the probability of getting rheumatoid arthritis is high, and these patients need to be referred to rheumatology for early treatment. But if it's less than 6, then we need to revise things. Next, please. So if someone has got swollen, painful joints, we do their bloods, the basic bloods like the blood counts, the liver count, the kidney count, looking for the presence of antibodies, and get some x-rays. So you look at the normal hand, we call this joint space. It's a lovely, nice joint space there. But in case of rheumatoid arthritis, it's all gone. There's damage, we call it erosion. Keep going, yeah. I won't go into the details, but as I said, rheumatoid arthritis is not just about joints, it's well beyond the joints. It can involve liver, kidney, skin, blood vessels, each and every organ of the body. If you want to put on a slideshow for now, because all the rest, I'll just show the pictures, won't go into much details. So this is how eyes are involved. Keep going, Dr. Shaku. Thank you. Lungs, heart, kidneys, brain, nerves, blood. Okay, we'll leave it at this slide. So now if someone is diagnosed with rheumatoid arthritis, what are we going to do about it? We call it multidisciplinary approach. So it's a combination of a rheumatologist, rheumatology nurses, physiotherapist, occupational therapists, and psychological inputs. We need all of them on board. Next, please. How do we treat it? The first thing is pain. So we get rid of the pain with anti-inflammatories, non-steroidal medication, but steroid is more potent. Steroids can be used in the form of tablets, intramuscular injection, or injection directly into the joints. But this is only a short-term treatment. We need a long-term plan in place to get rid of the inflammation at the cell level. So we use medication called DMARD, disease-modifying anti-rheumatic drugs. The common one you might have heard is methotrexate. If they don't work, we still have a number of other available, which are called biologics. So they work at the inflammatory pathways. They block them to stop the release of inflammatory cells, which cause the pain, swelling, and stiffness. Some of these medications are not safe in pregnancy, so we need counseling well before that. And they need to be stopped before planning pregnancy. It looks quite grim, isn't it? We're not talking about the joints, so many organs are involved, but no, there's a silver lining to it, okay? We use T to T, which means treat to target, hit it early and hard. So commencing the disease-modifying agents early is the way to go to prevent damage, erosion, functional incapacitation, and disability. We do an education session for these patients about their chronic condition, but also about the medication they go on. We call it a drug education session. So they get to know about the do's, the don'ts, when to take the medication, when not to take them. We screen them for infections, we do all the blood tests, and once they are on the treatment, we do regular blood tests to make sure their blood count, liver count, kidney count is within normal and the level of inflammation is controlled. So rheumatoid arthritis shares some inflammatory pathways with depression endogenously, but imagine if someone is in chronic pain, not being able to do their day-to-day activities, there's increased risk of depression. That needs to be looked into early during the course of the disease. There's a financial burden with it. It costs about 56 million to NHS and patients with the treatment costs. But if you look at someone who's in pain, so assisted living, ergonomic adjustment, reduction in the hours, early retirement, that all can have a negative toll on patients' mental well-being. We all know that diabetes, hypertension, high cholesterol, high weight are risk factors for cardiovascular mortality and morbidity. But I want to emphasize that having an inflammatory arthritis is an equally risk factors, and these patients need to be counseling about high protein diet, healthy dieting, quitting smoking, and above exercise to promote strengthening of the bones, tendons, muscles, and also increase bone mineral density. Now this is hope. These are called rheumatoid hands, and I can assure you that we don't see them anymore. Because of the biologics and medication, we get rid of the inflammation early, and they don't get to see this stage. This is a patient who had rheumatoid arthritis for more than 30 years. Next slide, please. This is another picture, and we are here to the end. Thank you so much. Any questions?
We are going to take questions, but this wouldn't be a community event if there wasn't a car blocking. Can we just shout out the car that's blocking in one of the speakers who needs to leave? Jeep LD21. Jeep LD21. If you could just, I think you're blocking another car in Jeep LD21. If you could just move that car so someone can actually get out here. Let's take some questions. Great topic. Thank you, Shama. I really enjoyed it. Shama, there's a speaker at the front who wants to have a question. Do you mind giving the microphone to them?
Sure.
Thank you, doctor. I apologize for a little coming later, but it's a very illuminating talk. At this age, I can only ask, what is the prospect of longevity with this kind of disease? What is the statistics of longevity? How you will show me NHS has improved the performance over 20 years?
So as I said, we don't see the rheumatoid hands anymore. That's the first thing. The most important thing is to control the inflammation, because when you talk about other sort of arthritis, we're talking about pain relief. But in here, we need to look at the root cause of the condition, which is inflammation. So once inflammation is controlled early during the course, this is how the comorbidities, the disability, the functional incapacitation, that is improved. And people can have a nearly healthy, normal lifestyle like the rest of the population.
Longevity.
Their life expectancy, as I said, the presence of the antibodies increases the risk of extra-articular manifestation. So if someone is having extra-articular manifestation, obviously in the form of cardiac involvement, lung involvement, that certainly affects the mortality and morbidity. And sometimes rheumatoid arthritis can be associated with a condition called Sjogren syndrome, in which there are dry eyes, dry mouth, and that can in turn be associated with lymphoma. So if you look at the indirect causes, it can certainly be affected.
There's a question at the back. Yeah, you had a question.
Yeah. Thank you, Doctor. Can the mental health issues manifest before the joint issues? Okay, thank you. Next question.
Hi, I've just a year ago had a drastic, I couldn't get out of bed. I said I couldn't get out of bed, that's how bad my arthritis was. I was in severe pain. I'm lucky to be sat here, to be honest. Well, I want to know, the things that you talked about, how the health service can help. Is there a difference? Are you from Preston hospitals? Well, basically, it seems to me what I was offered was totally different to what you are prescribing. And it seems to be, it's like a postcode lottery. Because I do feel NHS let me down. I've never had an MRI. What's happening, the situation for me is, at the moment I am suffering really bad back pain. Is that part and parcel of that? And also really bad, knees, my knees are always painful, but they can become very severe. This weather doesn't help. But what is it individually I can do? Because getting an appointment is a task in itself.
We're not going to be taking questions on getting NHS appointments. It's not a political conference at all. Please stay away from that part. But Shama, you can answer the rest.
Well, that's where we have come from.
Okay. So first thing, I'm sorry to hear about your unpleasant experience. Okay. Secondly, the sort of the basic infrastructure for all rheumatology departments, regardless whether it's Preston or Wigan, is similar. So you might need to get in touch with your department and relay your concerns to them. coming to the back pain and knee pain, so it's not impossible, but it's very unlikely for rheumatoid arthritis to involve big, large joints such as back and the knee. As I said, it's not impossible, but it's quite unlikely. It's a small joints. If you look at my hand, there are tip bones joints, the middle ones, and the bottom ones. The middle ones and these ones, these are commonly involved, and as I said, soft, squishy swelling in them, stiffness in the morning. Coming to your knees, you could have some sort of inflammation in it, but the common problem with the knees most of the time is osteoarthritis, which is a wear and tear arthritis, and is treated with pain relief, strength exercises, injection into the joint, and above all, lifestyle modification. 1 kg in our tummy doesn't put 1 kg on your knees. It gets amplified and it puts 4 kgs on the knees. So lifestyle modification, high protein diet, activity, strength exercises, they all help.
Hi, my name's Steve. I work in psychiatric work, mental health, and the boss here, the doc, has just asked me to make a few pointers. Can everybody hear me okay? Yeah. Bit loud. Hello, sir. How are you? Great to see you.
Nice to see you.
No, I'm glad you've come. Yeah. Okay, so my role in the work is as a counsellor, psychotherapist, and it's about talking. I'm not pill therapy, I'm talking therapy. Well, that's the plan. And just some pointers really today as to the kind of work I provide. And the first thing is that whether we're doctors, whether we're cameramen, whatever our role is, we are here as human beings. And human beings are somebody that's subject to stress and other issues, worry, loneliness, sadness, and it can affect us all. And it doesn't matter on colour, creed, religion or anything. And it's how we deal with that. And mental health is just as important as rheumatoid arthritis, in that often they go hand in hand, don't they? If somebody's suffering from bad arthritis, they can become depressed and they become isolated and they become worried about disfigurement. So that's where we all have a role, and it's about breaking the stigma. A lot of people are scared to talk about their mental health because they think it weakens them. And the amazing thing that whether we are a doctor or whether we are a psychotherapist or the cameraman, we've all got mental health. Some days maybe we feel a little bit more mental than others, but we've all got mental health. What do people see as the initial sorts of problems with mental health? Where would we see it happen? Where could it happen? In the workplace? Could be in the workplace. Could be me on the stage here right now. So it's stress, isn't it? That's probably one of the major things, stress. Anybody else? Any ways that you see mental health occur? Winter, yeah. That can be general malaise of winter, or it can be seasonal affective disorder, can't it? 75% of the population of the UK suffer from a condition that's called dealing with bereavement. Bereavement, yeah, bereavement's an awful one, isn't it? And I don't think we ever get over the pain. We learn to manage it, don't we? But it's an awful process when we lose somebody dear. So again, if we are suffering from bereavement or if we're suffering from grief, what do we do? Do we keep it in here, or do we talk about it? What do you think? What's best? Talk about it, because the problem.
We pray.
Oh, we pray. Yeah, they're talking to whoever's relevant is good in prayer, and if we talk to our friends or members of the community, it's very important. But I think a lot of people still don't do that. There's a stigma to it, and that is something we have to break through, the stigma of mental health. So what would you say the early signs of somebody with a mental health issue could be? I'll give you a clue. Are they permanently sad? Any other signs you would say? Who? Grumpy. That's fair enough.
Not involved in activities or like
isolating. Yeah. Okay. It's got isolating, sadness.
Sometimes feeling anxious when they're doing normal
Yeah, anxiety creeps in. We don't like the things we used to like. We can't be bothered with people. Any more? What about sleep habits? They tend to go. I'm on the 4 o'clock wake in the morning at the moment. I don't know why. Every morning I wake at 4 and then feeling sleepy by 6. I don't know what that one's about. Well, I do, but I won't bore you today. Well, look, so daily activities we've had, yeah? What about when it gets a little bit more serious? What about self-harm? That's a, you know, and that can take many forms, can't it? Yeah, but that's another serious one.
Shouting at others.
Pardon?
Shouting at others.
Yeah, but that probably goes hand in hand with your grumpiness. As long as you don't shout at me. So what's the antidote to that? We've heard about pills and tablets. What's the antidote? What we're doing now? Talking and listening. Yeah? And they're two vital, aren't they? You know, two vital factors. We need to talk.
I would stress praying.
Stress?
Praying. Praying is more important.
Praying.
I mean, I don't know the statistics, but I find more people who are religious, they were less stressed.
Okay. So definitely accept the prayer. And I think prayer is a big part of it, but I also think that people talking. How many people have felt isolated and lonely during their time on this planet? Anybody felt isolated, lonely, threatened, sad? Normal day at work for you. But yeah, so you feel that? And have you talked to people about those feelings or just keep them in here? Because I think the feelings... Brilliant. Friend at the other end of the phone, yeah?
Because me and my friends are all in Scotland. I moved here because of but for me, because I don't have many friends here, just picking up the phone and talking to them guys, you know, that helps.
Yeah, I go with that, talking to friends. So we've got prayer, talking to friends, and of course we can move into that other category of talking to professionals. I've got one walking towards me now. GP. Yeah? Oh, he's gone. But we've got GPs, and through GPs they come to people like me, psychotherapists, counsellors, and we're just average people. We understand, we don't condemn, we don't judge.
I've noticed, like, you know, even for a counsellor, I was told you've got to self-certify yourself, you've got to make your appointments yourself.
I think, well, certainly in our practice, the appointments would come through the medical centre. Yeah, I mean, but you can go and see counsellors, psychotherapists privately.
Yeah.
But you start to.
But even for the NHS, I got told that I've got given numbers, telephone numbers, and got told that you've got to ring these people yourself and make an appointment yourself.
Yeah.
Whereas, you know, sometimes when you're going through stuff, it's quite hard.
Yeah, go with that totally. You need that encouragement. You need
somebody to hold your hand and say, right, okay, I'll do this.
Well, for me.
Get sent away with telephone numbers.
Yeah.
So then,
well, I wouldn't agree with that. So what I think that you've got to be able to go through the medical centre, and if you've got a member of the family, that's what we do. I'm Blackpool area, so in Blackpool that's certainly what happens. Yeah.
Steve, can I also add hobbies? I found if anyone taking a hobby like dancing or singing, I know there's someone dancing here as well. It also makes this place management better.
Dancing and singing is very good, but please none now.
Photography.
No singing, the dancing now. No.
Or photography.
Yeah. Okay. What about healthy life? Got two more. Healthy lifestyle habits. What does that involve, Doctor? Healthy lifestyle habits. Diet. I can see yours is going well. and maybe exercise. Yeah. Exercise and with contribution from the corner with singing and dancing.
And photography.
Photography. Yeah, photograph. Reducing alcohol, yes, certainly here, yes, no alcohol. And any addictive habits, it could be smoking, could be anything, sir.
And nutrition, that's very important.
Massive, thank we got there, yeah, nutrition. We are what we eat. And, you know, these days, men of learned physicians like this gentleman to my right, your left, would say that we have two brains, one in the stomach, one in the head. And, you know, so it's... So, and the other thing is, how much self-care do we practice? How much do we actually look after ourselves? tends to be in our jobs, we just keep going, doesn't it, in the medical side of stuff. But do we ever give time, compassion to ourselves? Do we? And how often do we reach out and help others? I think that's a good way of actually helping ourselves. Yeah? Does that happen? Outside of our profession, do we help others? It's a big way. How long have I got, Doc?
You're finished, mate.
I'm finished. I could go on forever, but you're actually the best audience I've had on one of these little trips. So it's all about self-awareness. Don't be afraid to talk. Either speak to the likes of me or the imam or speak to community leaders, but speak to family. But there is no shame in having a mental health problem. We all have mental health. Yeah? We remember that. So anyway, thank you. Good to speak with you all. Have a lovely day at this wonderful meeting. Thank you.
Thanks, Steve. That's really helpful.
Thank you for inviting me. I'm Mr. Madan. I'm going to talk about cholesterol. So have the lunch, stock up on your cholesterol, because cholesterol is essential. Next slide, please. Basically, cholesterol is a combination of hydro and carbons. It is complex rings. Next slide. So it's essential for the all cell membranes, and cholesterol is in the middle of the cell membrane that gives it fluidity. Next slide. But cholesterol is also essential for testosterone, estrogen, cortisol. So hormones, waking you up in the morning, controlling stress, controlling how much water that you have, your blood pressure, your bones, vitamin D. So this is vitamin D, and this is cholesterol. So cholesterol is important for a lot of systems. Next slide. But unfortunately, cholesterol is a fat. It can't be transported easily in the blood. So it's in globules in the blood, and they're called low-density lipoproteins or high-density. The LDL basically takes the cholesterol to the tissues, whereas HDL picks up the cholesterol from the tissues, which is excess, and that is important. So it has to be a balance between the LDL and HDL. Next slide, please. Thanks. Yeah. So basically, most of the cholesterol comes from your diet, but it also comes from the liver, the gut, and the cells can make it because it is an essential component of cells. But it's a balance between the HDL and LDL that is important. Next slide. Arteries run from the heart to all tissues, to the nooks and crannies everywhere. And the heart itself is also supplied by arteries. Next slide. But fat in your arteries isn't just the result of cholesterol. Yes, you may have a high cholesterol, but the damage is being done by smoking, high blood pressure, diabetes, and weight. So it's not just a matter of dealing with the cholesterol and everything will be fine. So you have to control a number of factors. Next slide. So what happens as you get older, the arteries get less elastic, and you get where there is branching of arteries, little tear occurs. It can be repaired, but if you have high blood pressure, high cholesterol, then the cholesterol can go into the tissues. this damage is not just because you're getting older, but it's also as a result of smoking. Next slide, please. So what happens is that in the tear, cholesterol is deposited inside the artery, and you get inflammation and then scarring, same as any other wound. The lumen inside is still open, so nothing has happened yet, and most people may not even know about it. Next slide. This chap, smoker, basically half his main blood vessel in his tummy going to his kidneys and to his legs. He doesn't have a clue about this blockage in his arteries. You can see the fat here. Okay, he feels fine. Next slide, please. But if that bit of soft artery bursts, then you can get clot inside the artery. Next slide. If there's clot inside the artery, then there's a critical event. So it blocks the artery, there's no blood going forward, and it depends where that blood is going, which event will happen. Next slide. And that's the artery completely blocked. Next slide. So if it's in the heart, then these are the arteries going to the heart. If it blocks, then there's a risk of a heart attack, sudden death, and angina. Next slide. Whereas if it's going up to the brain, then you get a mini stroke. You can have a stroke in the brain, mini stroke, which you can recover from, but also you can get vascular dementia if the blood vessels, small blood vessels in your brain block off. Next slide, please. In the tummy, if the arteries become weak, then they can get bigger with blood pressure. And if you get an aneurysm, which is the blood vessel getting bigger, it's like a balloon. The bigger it is, then the higher the risk of it bursting and you not surviving. So that's an aortic aneurysm. Next slide, please. If the arteries become hardened due to the fat in the arteries, then they can block off and there's not enough blood getting into your arteries going to your leg. So what does that result in? Next slide, please. Pain when you walk, or ulcers on your feet, or gangrene. So cholesterol and the smoking and the high blood pressure can all add up to heart attacks, strokes, or blocked arteries to the legs causing ulcers and gangrene. Next slide, please. So what are you going to do about all of this? Well, one is going to be stop smoking, controlling the diet, the weight, exercise, but also controlling diabetes. Okay? And part of the equation is lowering cholesterol. It's only a small part. Next. So your doctor will have a whole list of medicines that he can use to reduce cholesterol such as statins, esmetab, and the newer ones, which basically mean that the liver can mop up the LDLs. Okay, so medication. Next slide, please. But going back to cholesterol is only a small part of controlling these symptoms. Remember, cardiovascular disease is a main killer in the population. Okay? So cholesterol, the weight, controlling diabetes, controlling high blood pressure, but also reducing smoking. Yep, I think we're done. Excellent, thank you.
Thank you.
I mean, basically, most people can have a high cholesterol, but the arteries can still be narrowed, but they don't have a heart attack. Okay? It's a combination of things, and if something's happens suddenly, like the plaque in the artery bursts, then it will completely block and lead to the heart attack. So yes, you can have a high cholesterol, and that's why it's important that to go along to your GP, get your cholesterol checked, and have lifestyle modification. In Scotland, the cholesterol is treated much more aggressively. They have a high incidence of heart attacks and strokes.
I really like the last question because it's succinct, brief, and it allowed the speaker to give a good full answer. We have another question at the back, please.
I just want to ask you, I have had a cardiac CT scan, and they said I've got minor plaque in my circumflex artery, heart artery, and they put me on statins, 10 milligram simvastatin and 75 milligram aspirin. Do I really need to take the statins? Because people are telling me statins are going to cause you this pain, muscle pain, that pain. So can you give me more advice on that?
So that old chestnut about statins. I don't think we're going to solve that on a Sunday here in Deepdale, because obviously this is a question that runs around all practices around the UK. But do your best, Mr. Madden.
Yeah. So basically, you've got disease in the arteries, so circumflex. That was one of the arteries that I was showing. And until it's more than 70% narrowed, you need these statins, and your GP may put you on things like aspirin or clopidogrel, okay, and tell you to stop smoking, do exercise, okay. But all of these factors is up to you. Yes, there are side effects from statins, but now there's a variety of statins that are available. And if one causes you an issue, you can try a different one. It is very, very important, because you don't want to get basically, if you speak to any doctor, he'll say, use statins. If you go to India, they'll give you a polypill, which has got aspirin, statins combined in it, to keep you alive.
Without further ado, Danny, please take us through the next section.
Thank you so much. Thank you. Welcome, everyone. First of all, I think I'd like to say a big thank you for you coming here today. So like Dr. Shakur mentioned, I'm Dr. Dunia Deni. So I'm a GP and lifestyle medicine doctor. And what does that even mean? So we're trying to create a movement where we are moving from sick care, which is where you come to us and we say, here's a pill for your high blood pressure, for your headache, for your diabetes, to how do we prevent you from even having the diabetes in the first place? How do we prevent you from having the heart attack in the first place? And even if you've got the heart attack and the diabetes, how do we prevent you from getting worse? So much so that you get complications like the ones that the previous speaker had mentioned. So today, we're going to be talking about stress and your health. stress is one very interesting thing that many people know about. How many people know about stress? Yes, okay. We're going to do a little bit of a vote. I think one of the habits I have is I like interaction, okay? So, first of all, is stress a good thing? How many people think it's a good thing? Okay, got a few people. Okay, good. How many people think it's a bad thing? Yes, okay. And I think the good answer when it comes to stress is it depends. We all need a level of stress in our lives. And that's the reason why from the moment you were born, as in literally born, you needed to be pushed out one way or the other to come out. And if you did not go through the birth canal with the contractions of your mother, you would come out quite floppy, because as you're going through that stressful birth process, the fluid that has been in your lungs when you were sitting in your mother's womb will not be squeezed out so that you can have lungs that are filled with air. Does that make sense? So even from the time you were born, you need a little bit of stress in your life to get things moving. And that's the reason why our bodies are such phenomenal entities, whereby in the morning, there is a chemical called cortisol that is released to help us to cope with the different stresses of the day. Cortisol usually peaks around 9 a.m. thereabout and it starts going up, and it keeps going till the time when it starts coming down. Cortisol is a chemical or a hormone that we call it, which helps you with regulating certain processes. So when you have cortisol rotating or moving around in your blood, it can cause your heart to go faster. It can cause your blood pressure to rise. It can cause your blood sugar to, if it's sustained, to be impacted in a way that is not particularly great because it's impacting on insulin. It can also cause you to have blood flow to the areas of your body where you need to keep your survival. So if for example, this door were to swing open and in came a lion, what's going to happen? Would you sit there and say, oh, kitty cat, you're amazing. You're going to get up and you're going to run. Nearest exit. I know that's going to be my exit. I will break through glass if I need to. But cortisol, what it does is when you have this high stress, your human first instinct is to survive. Get out of there. Either fly, freeze, or fight. And what are the parts of your body that helps you do that? Your legs, your hands. Not so much your brain. It's when you're thinking and trying to strategize, your brain starts saying, okay, you know what, I would do this instead of that. And so blood does not really flow to your digestive tract as much. And that's the reason why when someone is stressed, they tend to have digestive problems. They tend to have this bloated abdomen. They tend to feel like constipation, diarrhea, and all those other features that we normally call irritable bowel syndrome, IBS type symptoms. Because the priority is not to digest your food. The priority is to stay alive. And so stress in itself, while it's not a bad thing, when it is sustained, when it's high all the time, it can impact your health adversely. And so, moving on to what the causes of stress are. So what are some causes of stress? Parents. Amazing. I like that. Because yes, they could be a source of stress. Even children could be a source of stress. Doesn't mean that they are bad, but the spouses, okay, all right then. Now this is getting very interesting. Okay, now, so we put the spouses and the parents and the children into the social category. So there's some social factors, okay? Government policies. There are environmental factors that could cause stress. For example, if you were coming in today and in front of your house there was this high level of snow, would you come out? You'd be like, no, I'm going to go back in. You won't be here today because you'll be thinking about the stress to shovel all the snow from your front yard to allow you to move out. There are some other important things as well. Mental factors. So what are those factors? For example, if you are feeling a sense of anxiety, a sense of depression, a sense of, I don't think I can do this, disbelief in yourself, those can add to your stress levels, and those are factors that cause stress. The other factors are financial, and that's very important because you do not go to the shops and pay for your food with a smile. You need to actually put some money out. And that's the reason why many people get stressed, because they're going to work, maybe they're not happy in their place of work, or things are a little bit difficult. And because of that, rather than saying, I'm not working anymore, they can't quit because they need the money. Sometimes there are increase, of course, the rising cost of living is another factor which stems into finances. And all these are factors that contribute to our stress levels. So most of the time when you are experiencing sustained stress, it's not because of one thing that has happened. Most of the time it's many things, many layers. Maybe there is something that the parents said, or something that your spouse is expecting of you, or something that at work they've told you, oh, well, we're making some people redundant. And all that accumulates and increases your stress level, causing high blood pressure, causing you to have poor sleep, causing you to have forgetfulness, and that's another feature when you have sustained stress. You also have situations where people start to have their hearts beating really fast. I know that the next speaker is going to talk about the heart, so I'm not going to delve into the heart too much. But you start having palpitations because you're anxious, you're worried. Then you also start to feel this sense of worry that affects your sleep, so you don't tend to sleep well. And that in itself is a problem. In lifestyle medicine, we have got 6 pillars, and all these pillars need to be taken care of in our lives. I'll talk about them very briefly as we go along, but I just wanted to bring that out to you that sleep is one of the pillars. Minimizing harmful substances like smoking, alcohol, and all those other substances that affect our health is also one of them. Stress management is an important one of them. Nutrition. I know someone was asking about biryani earlier. Nutrition is important. Physical activity is also very important. And these are pillars that would help you to prevent the progression of ill health, will help you to feel empowered, to feel well in yourself, and prevent you from developing these chronic diseases that we talk about. So having talked about the different causes and the different effects of stress, you might be thinking, even thinking about it is stressful. Okay, so I'm not going to make you go through that process. We're going to talk about what can you do about it. When you're feeling an increased level of stress, what can you do? I have an acronym. How many people like acronyms? Yes, okay, I can see a few hands going up. The reason, when I was maybe younger, I would say, I think I'm still young, but when I was younger, I wasn't very keen on acronyms. I was like, oh, another LFT. We don't know whether it's liver function test or lateral flow test, But this time around, a lot of people have told me how important the ability to recall certain concepts is. So I'm going to use an acronym with you today, and it's called RESET. How many people have heard of RESET? So when something is going wrong, there is a problem, you can decide to panic and run, or you can decide to come back and say, it's time to hit that reset button. Where do we start from? Let's start again. Okay? Whenever we are in the, I'm a GP, so of course there are certain times we are using our devices, AMIS we use in the surgery where I work. And sometimes it's not working. The computer is not behaving itself. So we call IT, and do you know what they always tell us? Switch it off and switch it back on again, isn't it? So it's almost the same way. So that's why we're going to do a bit of a reset here, okay? Your body is always talking to you. Did you know that? And your body, initially, when it's talking to you to tell you how much you are going through, what you are experiencing, it would, first of all, start as a whisper. So sometimes you don't hear it. Sometimes you ignore it. You say, okay, you know what, I'll come to that later. Let me deal with this particular thing. And then sometimes when you don't pay attention to that whisper, it becomes a whimper. And that's like, please help me, come on, do something. Listen to me, do something right now. But then you don't listen. And then what happens after that? It starts to scream and shout. And that's where your blood pressure is through the roof, your blood sugar is not controlled, you start to feel dizzy, you have poor sleep, and we don't want you to get to that level. So regarding the resets that you would do today, and this is just trying to walk through simple ways that you can take action from today, from now. The R is to realize where you are. When you're realizing where you are, you need to stop. You need to stop and say, okay, how do I feel right now? You need to ask yourself that question. Some people do this only on the 1st of January of every year. But this is something we need to do regularly. So there might be something you can do maybe at the start of the week. Some people believe that the start of the week is Sunday. If that is for you, good. On a Sunday, you're not going to work, or maybe you are. You might just take 30 minutes in your Sunday to see, how am I today? How am I really? How do I feel? Where am I at in my stress management? What am I feeling like? Am I feeling really stressed or super relaxed? So by being able to realize where you are, it helps you to make certain plans going forward. So that is the R. And I've just given you a practical thing you can do starting now. You get back home and you say, I'm going to give 30 minutes to myself to realize where I am. The second thing is to evaluate what the causes are and the effects are of how you feel. When you're realizing how you are and how you feel, it is very important that you think about what has caused that. That's when I was asking you earlier, I said, what are some causes of stress? And we're talking about, social factors, financial factors, physical factors, mental factors. And all these things do contribute to the stress. So you will be able to evaluate what are those things that are adding to your stress. It could be your job. It could be your financial situation. It could be the fact that maybe that you've received a phone call from back home and people are telling you that, oh my goodness, things are tough, you need to send some money. That can be an element of stress. And so you need to evaluate what those things are. And when you do evaluate, one of the things that we do as humans is that we're very good at criticizing ourselves. I know I do that quite a bit. So whenever things go wrong, I'm like, what have I done? What did I do wrong? Okay? So we need to be very critical. We are sometimes critical, and we need to be very mindful of that. That is why in the reset that I'm telling you about, we've got S. S is so important, and that is where you exhibit self-love. While you are evaluating and saying, oh, this thing caused it, this contributed to it, I did this, I did that, express some love to yourself. Yes, it happened. Maybe you were the one that solely put yourself into trouble, but that does not mean that you need to criticize yourself so much so that you feel depleted. The self-love could be a situation whereby you just say, you know what, I'm going to take some time off work. Your self-love could be, look, you know what, I'm not going to go out today. I'm just going to chill in my house and sleep. Your self-love could be, I am not going to go into social media today. Your self-love could be, I'm just going to be mindful of who has access to me. And that's an important thing because you are an individual. You can't control what someone else does to you, what they think of you, how they feel towards you, but you can control how you respond to that. And that's the reason why I love this thing by Stephen Covey. Have you heard of Stephen Covey? He's the author of the book, 7 Habits of Highly Effective People. That's a must-read book. Sorry, I love books so much, so I'll probably give some more book recommendations. But he had this practice where you are in the center of a circle. And just imagine, you know how onions look like when you cut it horizontally? There's that inner part, the inner core, that's you. Around you, immediately around you, is your circle of control. Your circle of control is where you can do pretty much anything. You are the one that controls what happens there and what's going on here. Then outside that circle is what they call the circle of influence. So you don't control it, but you can influence it. I can't control my children, but I can influence them a little bit. You say, okay, oh, I don't think I would be happy for you to pick up the vape like your classmate is doing. I can't control them, but I can influence them so much so that they will not start vaping like maybe some of their colleagues are. Then outside that circle of influence, there is the circle of concern. Now that is where you really don't have any control. It's what's happening outside, how someone looks at you or feels about you or think of you. And that circle of concern is where you do not want to spend your time because it causes a lot of stress. Okay? So what we are going to do is focus on that circle of control and circle of influence and leave the circle of concern. So that self-love you're going to do are actions you're going to take today. And I'll be talking about that in the final step. The next thing, and we're talking about reset, aren't we? The next thing in the E is expectation management. Some people expect so much of themselves. And now, don't get me wrong. Please aim high. It's very good to aim high. Expect yourself to do what you need to do. But when you are setting expectations and comparing yourself to your peers, to your colleagues, to your friends, to your family members, that is where you really fall. Expectation management also involves you controlling the impact of people's expectations of you. Now, I coach mothers. I talk about health and well-being. And something I wrote about in my book, Every Mom is a Super Mom, is that very importantly, when you are thinking about making a headway in your motherhood journey, and this is going to be applicable to everyone in your life journey, you're not supposed to be doing what you think other people want you to do. Because everybody expects maybe, oh yes, you've got a clean house, you've got clean kids, you've got food on the table, you've got everything, and you need to be looking spotless. Sometimes it's hard. And so you need to tune into who you are and set your own expectations for you. So you need to manage expectations. Some days is the day where you are using your cape and you're flying around the place. Yes, super mom. And some days that cape is to wrap around yourself while you're crying, feeling very sorry for yourself. And it's okay. These things happen, but you can seek help. Now the T, that's a very important one, is to take responsibility. Nobody is coming to save you. You need to take care of you. You need to take responsibility for your actions and your inactions. Your ability to take responsibility is key to your well-being. Yes, stress will come. Things will come. Hardships will come. COVID can happen again, or something else with another name. These are things you can't control. There are some things that maybe you can control, but they are kind of gone a bit too far. But you can take responsibility and make a change today. And at this point, I'm going to kind of make a bit of an appeal to you to take responsibility. There are 2 things we are going to do together, and they would only take about, let me see, how much time have we got? We've got a few more minutes. Okay, good. It's going to take just two minutes to get these things done. So the first one is relating to a research that was done by Amy Cuddy. So she's based in America, and she talks about the role of power poses. Have you heard of that before? Power poses. Okay, so power poses, for those of you who like sci-fi or superhero movies, I do, I love it so much, you would know that Superman, how does he stand? Yes. Dun, 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 dun. Okay, good. We'll not bore you with that. So those are power poses. Put your hands on your hips and stand up tall. Some people stand like that, and some people it's just that stance. And so I invite you to join me in that stance, whatever that is for you, whether you want to go like that or you want to put your hands on your hips. But the research has shown that when you do, actually, even for about 20 seconds, stand in that power pose, your cortisol level comes down. Your ability to cope and face challenges goes up. And that is such a powerful thing. So you might be feeling stressed, but even in 20 seconds, you can stand up and have a power pose. And you could be crying there, but you could put your hands on your hips and say yes. Yes. That is a powerful thing you can start doing from now. So you can have a seat now. Thank you so much for indulging me. Now, the second very simple action that you can also do is something that we require to be alive, and that is breathing. Breathing is something that we probably were not taught how to do. The moment we came out of our mother's womb, we started crying and started breathing. So we kind of were forced into it. So nobody really taught us how to breathe. But there is a particular method of breathing, and I know there are several methods as well, but this particular one is a very simple one we can kind of quickly delve into. It's called box breathing. Why it's called box breathing is that you breathe in for a set number of breaths, counts. You hold your breath for a set number. You breathe out for a set number, and then you hold your breath for the same number. So it's this equal counts, okay? So what we're going to do together, we're going to breathe for just one count, and I'm going to use my fingers to count so that I don't, so I will breathe along with you, okay? All right, so deep breath in, 1, 2, 3, 4, hold, 2, 3, 4, breathe out, 2, 3, 4, and hold, 2, 3, 4. Now that is how box breathing is done. So it's 4, you can do counts of 4, you can do counts of 5, but it's equal. And what happens is if you do that for a few cycles, it calms your nervous system. It triggers the vagal response, the parasympathetic nervous system. I'm not going to go into that because it can be quite complicated if you're not in that line of work. But it also reduces that stress level. And so when you are feeling that extra stress, just stop, get your pose, take some nice breaths, and then you'll be able to move from that fight, flight, freeze into a place where you can think and solve the problem in front of you. This is something that you and I can do. Taking responsibility for our health and well-being with these simple ways to reduce our stress and to improve our health. Thank you.
That was fantastic as usual, Danny. Danny's a fellow of the Royal College of General Practitioners as well. Irfan Ahmed, just a round of applause, please.
Thank you very much for me. Yeah. Yes. So let me talk about why heart health matters, and that's very important. So we know that this heart, which is beating in our bodies, has been there since we were born, and is still working, and we need to look after it. But the very important thing about our heart health is that as Dr. Madan earlier spoke, that is one of the most common cause for any death is cardiovascular disease. I hope it works. Just got excited by Dr. Munawar, huh?
I think so. I think it just crashed when I realised Professor Munawar was right.
No, when you say cardiovascular disease, is that the same as heart disease?
That's a heart attack, stroke, including vascular disease, which earlier we mentioned. So cardiovascular disease is a big spectrum.
Right, okay.
Well, was just
Yeah.
Is it coming on? Yes, coming.
Yes, it's coming. It will come up, yeah. So what I'm going to do to stress the importance is that there are 6 numbers which I want you guys to go. We go through all the 6 numbers, and I will talk about. This is going to be very much guideline based, but I promise it's going to be translated in English. I'll try to avoid any cardiology language, but try to make it more English related so everyone can understand it. And we'll talk about all the numbers, and I'll tell you some very small basic things which we can do to really transform our lives. So there should be coming soon all the 6 numbers together. Sorry for this. It's coming down. It takes 9 minutes. I think it's quite a busy day for you since 1 o'clock.
Yeah. We're all here for you, though.
Yeah, thank you so much.
Just give it a minute. Is there any questions on anything at the moment, just while it's loading up? Yeah, go ahead, Salim, yeah. Give it, just take it while it's just loading. Yeah, we just got a question. We'll take that. The machines are loading up again. Yeah.
One of the previous doctors mentioned that tears in the arteries result in plaques. Does exercise strengthen the arteries to minimize tears, or definitely? So stamina exercises, high intensity exercise, or just gentle exercise?
It's a good question. Yeah.
Okay, so the question about exercise, I'll just mention about exercise, very important. Exercise to me is the best medication, okay, any exercise. And to be honest, doctors should prescribe exercise, okay. Exercise, any type of exercise, even walking, running, any exercise is good for your heart, okay. So exercise is one of the number 1 prescription should be for any practice, whether it's NHS, private practice, but exercise is number 1, and definitely exercise will help your heart. It will help your vessels. It will reduce the plaque burden. It can reverse the plaques also. Okay, so exercise is one of the most important prescription which you should use. Oh, that's good.
So
go back.
Sorry, quick follow-up.
Yeah.
Exercise can reduce plaques.
Yes, can reduce plaque burden, can reduce plaques, and can stabilize the plaques. A heart attack happens when the plaque becomes unstable, breaks. I'll show you for the slides. It'll come through. Okay. So why these numbers matters? To be honest, your heart doesn't beat for you only. It beats for your children, your family, your parents, your wife, and your loved ones. And looking after your health is one of the greatest gifts you can give your family. I think it's one of the most important gifts, in my opinion. And surprisingly, all these cardiovascular disease, 80% is preventable. This is a big surprise that you can prevent all the cardiovascular disease. There are risk factors which are modifiable risk factors which we can change. Some are unmodifiable, like genetics, which we cannot change. Ethnicity we cannot change. But this does not mean that this should say that we have a bad luck. The other modifiable factors we can easily change. We have to make small improvements, and I promise they will make a big impact. Even just give you an example, just a 2 millimeter drop of blood pressure in a systolic blood pressure can lower your 10% risk of dying of stroke. This is 2 millimeter only blood pressure drop. It's so important, 2 millimeter, and I'll show you there are many things where you can drop your blood pressure to 6, 10, 12, 20 millimeter. This is only 2 millimeter drop of blood pressure. And LDL, the bad cholesterol, which we call simple, and even one number lowers your cardiac events by 25%. So these numbers are like your car dashboard. If you see but unfortunately, there are no flashlights in humans where you can see, but they're like your blood pressure, which has been there as a silent for years and years, still causes a problems. Next slide, please. So these are the 6 must-know numbers, which I think everyone should know, and this should be your New Year resolution that everyone should know his 6 number. What's your blood pressure? Is it 130/80 is an ideal blood pressure? We do allow 140 over 90 up to, but 130/80 is ideal. Heart rate 60 to 80 is ideal. BMI 20 to 25. A waistline less than 37 inches. A waistline less than 32 inches for females and 37 for male. LDL, which is the bad cholesterol, should be less than 2.6 for anyone, general population. But those who are high risk, I'll show you, they need more strict control. And very important, your sugar, HbA1c, should be less than 42. These are the 6 numbers everyone should know. The 4 numbers which you can do at home, the the rest too can be done at any GP surgery. It's just a blood test. Next, please. No, we'll go by each number one by one. The blood pressure. Now, what is blood pressure? This is the force of the blood, which basically is against the resistance of the arteries. If you see, these vessels are very nice, open, normal. But once somebody has a blood pressure, they become stiff, they become narrow, they become inflamed, and the inflammation, there's swelling, and they become so that they get eventually blocked. Nobody will have a symptom of hypertension till it gets blocked. So this hypertension has been there for years and years. So it matters for even a 20-year-old who has high blood pressure. He might be fit, healthy, playing football, but he has high blood pressure that needs to be addressed. The risk of blood pressure, it doubles like a risk of heart attack and double. Even if you have slightly increase of blood pressure of 20 millimeters, somebody's blood pressure is like 135 and goes to 155. His risk of getting a heart attack is doubled. Though it's just a 20 millimeter rise of blood pressure. But best is home blood pressure monitor. Everybody should have a home blood pressure monitor where they can check their home blood pressures. They should keep a reading. And normally in the morning, the blood pressure is slightly high. In the night, it's low. That's a normal physiological phenomena. But very important, the lifestyle changes can drop the blood pressure. Lifestyle changes, what are those? These are like exercise, walking, eating healthy, low salt. They can reduce the blood pressure up to 20 millimeter mercury. So, in fact, just taking just low salt diet is like a medication. It's like a tablet which can reduce the blood pressure. Hypertension is proved to be a silent killer. So that's one of the most important number everyone should know. Okay, next please. Resting heart rate. I think we ignored this resting heart rate. The resting heart rate is 60 to 80 beats per minute. This is normal, ideal. It can be vary from 50 to 90. Anybody, young people, athletes can have a heart rate of 50, which is fine till they don't have any symptoms. But 60 to 80 should be the target. Above 90, the more the heart rate goes up, the more the cardiovascular risk increases. For example, somebody's heart rate is 100. He has twice the risk of somebody whose heart rate is like 70. Similarly, most of the studies have shown that increase the heart rate above 80 increases the cardiovascular mortality. So high heart rate basically means that you're not fit, you're not exercising, you're not walking, and also, as my colleague has mentioned about stress. Stress is a very important factor for high blood pressure. You should have a balance in your life, especially with fitness, autonomic balance, and also balance with regarding stress things. Resting heart rate is improved by exercise. It's better to measure in the morning. And one thing very important, if you can see a stairs and you see your heart is going to 120, it means your heart is politely saying you that you need to exercise, please. Okay, thank you. Now, this LDL cholesterol, this is the real villain. I know there was a lot of chat before with Dr. Madan about LDL cholesterol. As LDL cholesterol is one of the causes of heart disease, it's not just associated. And the targets are very simple. You just need to know your bad cholesterol. So I know there are good cholesterol, bad cholesterol, different type of cholesterol, but bad cholesterol is one most important. Everybody should know his LDL cholesterol, which is the real bad villain. The target should be 2.6. This is for those people who are normally very fit and healthy, and most of you are here. But if you have a high risk like high blood pressure, diabetes, the target is strict 1.8. The target should be less than 1.4 if you have very high risk, like you had a heart attack or a stent before. But most important, if people keep on getting heart attacks, bypass, the target should be even less than 1. It is said that the lower the cholesterol, the better it is. I'll come into the discussion about statins. There was some discussion about statins. I'll come in a minute about it. But very important, the first thing is lifestyle, honestly. If you don't do lifestyle, your medication doses will increase, 1 tablet, 2 tablets, 3 tablets. Now we've got injections also available. You go, but lifestyle changes are the most important thing. You need to make sure that what you eat, what type of diet you take, Mediterranean diet, other diet, that's important. We have medications like statins. Now, I know there's a lot of discussion. People stop me in the corridors and ask me, oh, I don't want to take statin, dementia, side effects. I tell you one thing, there are about 120 studies on statins. There are thousands and thousands of patients who have had research. I know 1 or 2 patients might have side effects, but please remember, your own loved ones, you don't want them to die of heart attack. Somebody can have muscle aches or pains. 1 or 2% of my patients have muscle aches and pains, but it's very rarely I stop the statins. There are so many different statins. You can try 1, 2, 3. Now there are non-statin drugs which are very effective. But the LDL cholesterol is the most important target. They are now injectables. You can use injectables once every month, once every 3 months, or even there are injections which you can just use 2 injections, 1 a year. But they are used. But I think cholesterol should be addressed. We should not get into the discussion about, oh, statins causing this or not. But important thing is the LDL cholesterol. There's a lot of bad press about statins, and I know that as the news, if there's a scary news about one thing, but please, you should know that there are 100 other patients who are not having any side effects, not heart attacks. This is what the statins are doing. And very important, the lower the cholesterol is, early you reduce the cholesterol, the better on the long term. There's a thing called cholesterol burden. We need to reduce that. That's the most important thing. So you should know your LDL cholesterol. That's very important. We can intervene. We can give you lifestyle changes, advise medicines, and there are other tests available like cardiac CT angiogram, other like stress tests we can do where we can see whether somebody has a risk of getting a heart attack or not. Next, please. Sorry, if you go back, sorry, one thing before. So if you see this is a normal artery, there's very good blood flow going through it. And this is what cholesterol does. This is the plaque. This is like a toothpaste which is accumulating. People say, oh, I'm not taking my statin, I don't care, I don't have any symptoms. But this is what your arteries are doing if your cholesterol is persistent high. So the arteries eventually they will block. Next. Second thing, I know my colleague diabetic consultant will discuss in detail, is your HbA1c and your glucose levels. This is also a very important risk factors. Everyone should know his HbA1c level. What is HbA1c? It is a 3-month average of your blood glucose. Simple. Fasting blood glucose is also good. If you have glucometers, you can check it. But fasting glucose does affect with your stress, your sleep, with what you have eaten on night before. But HbA1c is more reliable. It will give you an average of 3 months. It's like a CCTV camera of your arteries, of your body. What is the blood sugar doing for last 3 months? So it should be less than 42. 42 to 47 is pre-diabetes, and diabetes is 48. Regarding fasting blood glucose, I know most of us, we have glucometers, we can check it. Normal should be less than 5.5. And above 7 is diabetes. Less than 6.9, from 6 to 6.9 is pre-diabetes. But diabetes is equal to cardiovascular disease. If you have diabetes, you will get a heart attack, you will get a stroke. You need to manage diabetes very, very seriously, okay? Lifestyle prevents diabetes by 58%. This is what even we have seen in studies that people who have early diabetes with lifestyle changes, weight loss, and with good diet, especially avoiding sugary things, they can reverse diabetes. But weight loss, 10 to 15% times, and about 50% of the patients in studies have reverted the diabetes back to. So if somebody has diabetes, they should not panic. They should contact their doctor and get more regime like weight loss and lifestyle changes. Thank you. Next. Now, BMI. What is BMI? This is a body mass index. It's a very easy thing to do. You calculate your weight in kilogram and height, and then divide it, and you get a graph where you say what BMI is. BMI should be between 20 to 25, but BMI does not differentiate between fat and muscle. Therefore, somebody who's very muscular might have a same BMI as somebody who's very fat. But the better thing is a waistline, which should be less than 37 inches in men and less than 32 inches in women. And it's proven that waistline, the lower the waistline is, better and reduces the cardiovascular diseases. Because waistline gives you the idea of visceral fat, which drives metabolic risk. Okay. The South Asian populations are very high risk. Earlier, I know somebody, another colleague basically was answering, Afro-Caribbeans are also very high risk. In Middle East, people from Middle East are very high risk. So waistline matters a lot, okay? Next, please. So there are many diets, plans like Mediterranean diet, DASH diets, basically all diets. Basically, these are the ways, these are the activities what we do. DASH diet is the diet which is used to reduce blood pressure, basically very low salt, but high in potassium, but more like natural foods. And that the Mediterranean diet is very fair. Whatever diet you follow, these are both heart healthy. Main thing, they should have high amount of fruit, vegetables, nuts, and fiber in them. They should be low processed food like sugar and salt. Okay. And definitely salt reduction lowers the blood pressure. Very important, 30% reduction in cardiovascular events is seen if you lower your blood pressure, control your blood sugar, and you're on proper diet. So eat naturally, avoid factory foods, avoid takeaway menus. Next. These are the risk scores which all our GPs and cardiologists love them, but they're very simple. These are these are our crystal balls which we can predict what the future is like. We in UK use Q risk 3, in Europe they use score 2, and in USA they use ASCVD scores. What is Q risk 3? This will tell in the next 10 years what is the chances of somebody getting a heart attack. These are like weather apps. So if it says that there's a 70% chance there's going to be snow tomorrow, or there's going to be rain tomorrow, it just predicts basically. But it's very important. Like if there's rain tomorrow, I'm not going to miss my umbrella. I'm going to take my umbrella with me. I won't say that, oh, I'll just take the risk. Similarly, if the Q risk of somebody is 20-25%, then the next 10 years he's going to get a heart attack. I'm sure that person will get his cholesterol checked, will get his blood pressure checked. If there's a problem with his blood sugar, he will get it treated. He will go on lifestyle advice. These are very important scores. And when you go to the GPs, they do that. They help to make shared decision making, and we should always do it, especially in people who have family history of heart problem, chronic kidney diseases, who are smokers, and also South Asian background. They basically predict that, oh, are you going to get a heart attack in next 10 years or not? And if you have to do something for it. Okay. Next, please. Very important, physical activity, as I mentioned before, any activity. But ideally speaking, 150 to 300 minutes of moderate walk every week, or 70 to 150 minutes of like running every week. And strength training should be always there, as you asked before, that there should be 2 or 3 sessions of strength training. That's very important. Even if you are doing something for 1 hour, even if you stand and go for a walk for 10 minutes, that's very important also. There should be at least 7,000 to 10,000 steps per day, but now new studies are saying even 25,000 steps one should do. The more the steps you do, the more.
Who does that? I want to know who does 20,000. You don't do it.
I don't do it. To be honest, I don't do it. I hardly do 10,000. Exercise improves everything. Okay, next. But it's cheap. Exercise is cheap and it's free, and there's no side effects, I tell you. Smoking and vaping, alcohol, very important. There's no safe level of smoking. Even 1 cigarette a day increases your risk of getting a heart attack 50%. I know there's a long things about smoking. Dr. Munawar mentioned about lung, other things. Quitting it halves the risk in 1 year. So if somebody has stopped smoking for 1 year, it will half his risk, and in about 5 years, it will zero the risk of getting. So smoking, vaping, nowadays we use vaping. Vaping is not harmless. I want you to make it very clear. It's like vaping is only used by doctors if they only advise to those smokers to help them. It's not for the teenagers, it's not for young people to start vaping. It's like if you are not having a headache, why will you take daily a paracetamol? So vaping is not the problem with vaping is new. It's new. The other important thing with vaping is that these young people are just in the adulthood. We don't know the long-term effect of vaping, but there is a serious cardiovascular, respiratory side effects coming from vaping. We need to support these people. And more important, I think, if you give up smoking, alcohol, vaping, it will definitely improve your bank balance. Next. Sleep, stress, and mental health. Dr. Duni did a very excellent talk, and I totally agree with her. We should aim to at least sleep 7 to 9 hours. It has shown that people who sleep less than 6 hours a day are at risk of getting cardiovascular diseases like heart attacks, strokes. So at least try to sleep 7 to 9 hours. It can be like you sleep 4 or 5 hours at night and 4 or 5 hours during the day. That's fine, but at least 7 to 9, 24. We need to recharge ourselves, okay? Poor sleep increases your blood pressure, your glucose, and there's a condition called sleep apnea, which is a very high cardiovascular risk condition. It causes arrhythmias, atrial fibrillation, which itself is a risk of strokes. So the sleep apnea usually happens with a combination of stress, sleep, and a high BMI. Okay? And as you had mentioned earlier, stress raises your cortisol and inflammation. Very important, mindfulness, exercise, they reduce blood pressure. Your prayers, if you pray, that also reduces blood pressure. So prayers are very good. So these are part of recharging yourself. Okay. Next. And we need to do these community prevention events more like these one, where we can make our community aware of it. And thank you to Dr. Shakur for arranging this. It's an excellent event. We need to get this community blood pressure screening. We need to make sure that people understand what salt and sugar are and how they're causing. In Finland, a study has been done where they have reduced the salt and sugar, and the risk of cardiovascular mortality was less than 75%. School is the basic thing. We need healthy children. We need our children to develop healthy habits. We should start from school. Once they adopt healthy habits, they can participate with us. And also all the high risk groups like South Asians and other Afro-Caribbeans, Middle East, and people from these origins, and especially smokers who are smoking, they should be always screened for blood pressure. Alcohol is also a very important factor for high blood pressure. That should be also reduced. The recommended units less than 14 units a week. There are social determinants, which is a huge thing, which from economy point of view. So we need healthy communities for healthier lives. So the big 6 number, this is about. Remember the blood pressure, 130/80, heart rate 60 to 80, BMI 20 to 25, waistline less than 37 for males, less than 32 for females, bad cholesterol less than 2.4, and HbA1c less than 42. So all these, okay, it's very important. Remember, prevention will save the lives. So it's very important you make small changes in the, even if you make one change, this will help you in the long term. But if you can make all these 6 changes and make sure you keep an eye on all the 6, it will transform you. You need to track your numbers regularly. I'm sure the lifestyle can beat genetics. Share knowledge with your family. Your heart age must be younger, okay, than what you look like. Next. So very important thing, know your numbers. The beautiful thing about heart health is this, it's never too late. And even a small change today can make a big difference tomorrow. Thank you. Eat healthy and stay healthy. Thank you.
That was a wonderful, thought-provoking talk, Dr. Ahmed. Many thanks. I learned a lot. I had the benefit of having the slides beforehand, so I knew, and I was thinking about it overnight as well. So thank you so much. There's a lot to take in there, actually. Today isn't just about listening to talks, though. We can do that any day. It's all about what do you do with the information when you go and see your friends, your family, when you go home, you go back to your workplace. How are we disseminating the information here, and what changes are we making? That's important. I think there was a lot of interest there. Any questions for Dr. Ahmed? Yeah, it's the usual people asking questions. I want to take questions from anyone first before. There's a couple in the front to hijack the questions. Is there any others who want to ask anything about it, first of all? Yes, absolutely.
You know, when we go to the doctors, they check our cholesterol. Do they also check the inflammation levels?
So a simple question there. We go to the doctors and they check our cholesterol. Do they also check our inflammation levels?
Basically, the doctor don't check the inflammation level. The inflammation level is done by CRP, other infections, markers like that. But definitely the most important thing is that the LDL cholesterol itself causes inflammation. If you can get it down, it basically means that you can get the inflammation down. So LDL is a marker for inflammation, but there are other inflammation markers who the studies have proven that they can cause inflammation and cause the arteries to inflame. But LDL is one of the major factors which doctors check.
That was an excellent question. Are there any other questions at the back? Anyone want to? Otherwise, we're going to go to... Yes, go ahead. Yeah, short question, please.
I'm not purposely to ask you questions because I had a heart attack, so I want more answers to my anxiety. So when I recently had a heart attack, I've been told I love exercising in the gym and so on. All that is stopped. My tuitioning is stopped as well. So that's brought a bit of mental stress. So when is the right time to resume everything? Though I booked an appointment with Heartbeat on the 17th of December. So when shall I resume to normal activities?
So it's about asking after heart attack when to resume normal activities.
So definitely cardiac rehab. I'm the lead for the cardiac rehab. I run the Heartbeat and with my colleagues. So the Heartbeat is the best thing you should join. And because what they will do, they'll resume your exercise, they'll assess you, they'll make you walk first and then make you even run or exercise. So it is a point you need to reset yourself slowly, and definitely you need to see Dr. Duni, people like your GP for stress management. So you need what has happened. It's a time to start a new life now. Okay.
Any other questions before we move on to, I guess, our keynote speaker in a way? We have a lot of good speakers today. We're at the Golden Triangle. Those of you familiar with India, we've got obviously the consultants from Royal Preston Hospital this next hour and a half. They all know each other very well. Dr. Irfan Ahmed, Professor Munafa, and then Dr. Kazi. So it's a really golden part of the actual agenda coming in now. There was a question here.
Yeah, I think Tali wanted before. You want to? Okay.
After this, yeah.
Right, Dr. Ramid, thank you very much for your lovely talk. I'm an academic, so I'll ask you some critical questions. One thing is, if I may say, if you don't mind, these are very middle class results you're showing. But there is also unequal health, unequal distribution of health. So how does the postal code lottery also helps? If you're living in a very low income area, then if you have got 2 cars, you get less heart attacks. You've got double glazed glasses, you get less heart attacks. So wealth distribution is also important. That's one number. And number 2, I know you're also coming to study question, you're all avoiding, but the other day my brother from Newton is a good professor than me. He told me they have withdrawn, Americans withdrawn 10, 20 and 80. So he's having harmful effects. So no matter what you say, doctor, this is a scandal, you have to accept it.
I think we can dismiss the second question. I think, yeah, let's do the first one.
What was the first one? I forgot.
Just about the health inequalities.
Yes. So definitely, I mentioned about social determinants. That's the huge factor. In basically, that's why the people with low resources who do not have enough good healthy food, money, basically that makes a difference, and they are more prone to eat heart attacks and eat unhealthy and do less exercise, because that's definitely a social factor is there.
So there's a political factor.
That's a social, definitely that is. I can't disagree with it. Okay.
Jazakallah khair, Fahim. First of all, thank you very much again for the kind invitation and a fantastic program. I do apologize for not attending the entire thing. I've got 2 other commitments. I've come here and I've got to rush off as well after this. It's amazing what you're doing, not just here, but also other programs that you continuously. I don't know where you get the energy to continue. Probably come from your dad. And thank you to Irfan for stepping in. I was stuck in traffic after another commitment, so apologies. My topic given to me is very catchy. It says stronger lungs, stronger life, TB, smoking and lung cancer. And what I'm going to do is actually make it interactive. So all of you here can hopefully participate in the next few minutes. You're not able to hear me? Okay. I hope all of you will take part in the presentation. It's interactive. It's simple interactive presentation. So, stronger life. So I'm going to cover this under the following headings, next 20 minutes that I'm going to speak. First of all, facts about lung cancer. Then smoking, shisha and vaping, which Dr. Ahmed already touched upon. A little bit about lung cancer screening. And then finally about tuberculosis. So, facts about lung cancer. The gentleman at the back there, can I ask you, what is the most common cancer in the UK? You're busy talking, so I thought I'll pick on you. Sorry?
I want to say.
Yeah. It'd be lung
or breast.
Lung or breast. What does everybody else think? What is the most common cancer? Skin cancer. Lung cancer. Jannat says lung cancer. Prostate cancer. Okay. 2 of the correct answers appeared in there, so I'm going to give you the answer now. And it's going to be very interactive. I know you're discussing something very important, but if you bear with me just for 20 minutes, you'll go away with some learning points, I hope. Okay? So, the most common cancer amongst women is breast cancer, and the most common cancer among men is prostate cancer. So, you've got to give your dad the prize. Huh? So, but overall, if you look at it, if you look at lung, it's not too far behind. So, those who said lung are also right, because if you combine these two, men and women, it's still very high up. So, between the two sexes, if you take 2 genders, very high up. Now, what is very, very important to note, however, is that lung cancer is the biggest killer. Yeah. So, you may not know this. Every 2 minutes, somebody in the UK is diagnosed with cancer. Did you know this? No. And every 4 minutes, somebody is diagnosed with lung cancer. Is that common? Lung cancer is the biggest cause of death. So we mentioned breast and prostate. If you put breast cancer, prostate cancer, bladder cancer, leukemia and a few other things, still lung cancer kills more people than all of that put together. 1 person dies every 15 minutes. So very sadly, by the time I finish this talk, nearly 2 people would have died of cancer, lung cancer. And the worst bit about lung cancer is 1 in 10, that's 10%, die within a month of diagnosis. Lung cancer not only kills, but also causes a great deal of suffering. Unfortunately, it's not one of the cancers which people develop and then die. There's a lot of suffering which comes with this. And that's why we normally not only focus on the far end of trying to cure cancer, cure people, but also on managing them well, ensuring that they're free of symptoms, free of discomfort. The reason for this abysmal statistics with lung cancer is this: because lung cancer is not easy to diagnose. 2/3 of lung cancer is diagnosed as an advanced stage. That's why it's such a big killer. Secondly, for the same reason, 5-year survival with lung cancer is 21%. That is, 1 year survival, by 1 year, more than half are dead. And by 5 years, 80% have passed away. So terrible statistics. And what makes it worse is the fact that some parts of the country, the mortality rate is higher. And that includes northwest of England. Blackpool is the winner here, unfortunately, very sadly, when it comes to lung cancer related mortality. And lung cancer is easy to miss because...
I want to see the better ones.
Which one, sorry?
The one before, slide.
This one?
See on the right hand side, you can see all the rich people are doing better lower.
Yes.
They're all rich people live there.
Correct.
So they have got less cancer.
Correct. They pick up early, they're well educated, they receive treatment early, and this is what we're going to make a difference with. In the second section, I mentioned what we're going to do about that, or third section maybe. Now, so lung cancer is not to be neglected when you get symptoms suspicious of the cancer. Persistent cough, breathlessness, coughing up of blood, red flag. So, chest pain, weight loss, loss of appetite, repeated chest infection, change of voice, hoarse voice, and some other symptoms. And actually, in the UK, we have a very good systematic service to diagnose and treat lung cancer just like any other cancer. Cancer-related service diagnosis is one of the best in the world. So we've got the service free of cost. GP refers to the specialist. There's a fast-track mechanism. We take a history, examine, do a chest X-ray, do the necessary scans, plan a biopsy. We have a team approach, and we support the patients throughout with specialist nurses. So all of that under one roof. Nowhere in the world do you get that. Early diagnosis is the key. There's a lot of support available. I'll touch upon lung cancer screening. But key, most important, crucial intervention is smoking cessation. Dr. Ahmed already mentioned about the importance of smoking and its dangers as far as the heart is concerned. I'm going to very briefly touch upon smoking, shisha, and vaping. Now, another opportunity for you to interact. So, we've been talking about smoking. You know, we came to know nearly 50 years ago that smoking is a killer by following doctors who are smoking and doing a study those days. What I'm trying to say is smoking was not considered a problem. The same thing is happening with some other things now, whether it's shisha or vaping, we don't know. So unless you follow all these patients, that time doctors were reporting their smoking habits, and what happened? They ended up dying of lung cancer and other conditions. The famous Richard Doll and Pito study proved that smoking kills. Prior to that, people were distributing smoking cigarettes like Smarties. You would have come to the meeting like this, we would have given you all cigarettes, go and enjoy. That's what happened 50, 60 years ago. Now Fahim is serving biryani, I think, or coffee and stuff. In North America, in the guidelines, there's a paper, very nice paper, about active smoking and effects on the lungs besides lung cancer, and the long list of problems that can cause. So you see here, this is normal lung. This is what it should look like, pink. One of my jobs in Royal Preston is to do a keyhole procedure to look inside the chest with a little 1 centimeter incision, small incision, and a look in. I'm absolutely amazed. I've been doing it for 25 years now. But as to how smokers' lungs look so different from non-smokers. So different. What do you think is this condition?
Lungs.
Lung related. What is the problem? The patient is on oxygen. So this patient has got COPD, smoking related lung disease. This is lung cancer. What is this condition? Asthma, probably. Receiving an inhaler. And what is this condition?
Diabetes.
Diabetes. Very educated and interactive audience you have here for him. No, the reason I'm showing is so smoking can also affect diabetes directly or indirectly. And heart disease, already you had a fantastic presentation by Dr. Irfan Ahmed. What is this?
Fertility.
Fertility. Smoking can affect fertility, especially in women. And what is this? Why am I showing this picture?
Prematurity.
Premature births because of smoking in pregnant mothers. And what is this? Blindness. And this? Stroke. And this is other types of cancers which can occur due to smoking. So many different ways that smoking can affect people. And you've answered it all correctly. What about e-cigarettes? I get asked this question repeatedly. Are they safe? What do you think? At the moment, we do not have very clear idea of the outcome, but all the pointers suggest that they are unsafe, slightly better than cigarettes as far as we know, but not without risks. There are a lot of problems because the vape liquid is not controlled. So many different vape liquids are used, and they can contain dangerous chemicals including heavy metals like lead, nickel, chromium, which are known to cause cancer, a number of other problems that can occur with vaping. What we do see also is something called VALI, vaping-associated lung injury. Young people have died because of severe respiratory failure as a consequence of vaping. So that can also occur. There's also a synergistic effect between vaping and smoking. So that's something we need to be aware as well. What about shisha? What about shisha? What do you think? Safe?
No.
You don't think it's safe?
Throat cancer.
Okay, yes. Tobacco chewing, shisha. There's a water pipe known as shisha, is prevalent in the Middle East. But I'll just give you the headline in the interest of time. Shisha has harmful chemicals, including several human carcinogens, and it is believed that even passive smoking can cause major problems in the lungs. A session of shisha smoking for 40 minutes, according to this paper, is equivalent to smoking 100 or more cigarettes. So it's not without risks. Sadly, this is being practiced in a widespread fashion. I just want to mention a few minutes.
Question about shisha in particular. Now with shisha, they don't use, is it tobacco, they use something else?
Yeah, there's a lot written about this. It'll be a lecture on its own right, and there's not enough hard data, but all the scientific data that's coming through so far suggests that there are a lot of chemicals, a lot of toxic products which can be very harmful. We will know more in due course. So,
Is there a lot of nicotine? Is it molasses? Is it nicotine in shisha or there's no nicotine?
yes, quite a lot of shisha has other carcinogens, other chemicals, including nicotine. Very briefly mention about lung cancer screening, and then I'll finish off with tuberculosis. Lung cancer screening. What is lung cancer screening? Why lung cancer screening? Unfortunately, I told you about the survival, a poor survival with lung cancer. It is because lung cancer is very difficult to detect. Often, you have it deep in the lung. Very difficult to confirm that it's lung cancer. The lung architecture itself, like the branches of a tree. So you don't know where the problem is. If you try to find, you get lost inside the lungs. One of my other jobs is every week, twice a week, I do bronchoscopy, which is putting cameras into the lung and using navigation equipment, just like your GPS, to try and find these cancers. But it proves to be a real challenge. And therefore, the only way forward for us, besides smoking cessation, if everybody stops smoking completely, 100%, in a few years you'll see a progressive decline in the incidence of lung cancer. Failing that what we can do is to screen and pick up cancer early. So when it's early, you can get cure. You can resect it out. And so we now have in Preston, for the last 8 months or so, it's 6 to 8 months ago it started, lung cancer screening. Age between 55 and 74, if you're in that age group, and if you have ever smoked, you should have got a call. You should have got an invitation to join the lung cancer screening program. Don't ignore it if you get the invitation. It's very straightforward. The invitation letter comes to you. You can ring and make an appointment. Initial screening is over telephone by a specialist nurse who will go through a series of questions. And then if you are at risk after the telephone appointment of developing cancer, based on that questionnaire, you'll be invited for a scan. And the scan is not in the hospital. You don't have to worry about parking when you come to our hospital or paying for the parking. This is in a car park. You know which car park? Tesco, the big Tesco where Morrison's was. That's where it is. So straightforward. You come there, you have a CT scan, and then after that you decide, based on that, it goes to a specialist radiologist, a scan specialist, and a multidisciplinary team who will tell you whether there is any suggestion of cancer. If anything else needs to be done, it may be follow-up, it may be monitoring, it may be surgery. So, very effective screening program, because in Lancashire, because it started first in the high prevalence area, that is East Lancs, Blackpool, that's where it started. Higher incidence of smoking, higher prevalence. And then it's made its way now, after 3-4 years, to Preston. And then it's moving to Chorley. So it's moving sideways. So throughout the country, this is what's happening. In Lancashire alone, more than 100,000 people have been screened, and nearly 400 cancers have been detected. Now, if you look at the Preston data, very early figures, more than 5,000 people have been screened, and we have a handful of cancers which have been detected. But for those people where the cancer has been detected, there's a definite chance of achieving complete cure. You remember the figures I told you in the beginning? 10% die within a month of diagnosis. More than 50% are dead by in a year. So, final topic for me today is tuberculosis. All of us here would have come across somebody who has been diagnosed with tuberculosis, especially if you are from a TB endemic country. So that may be anywhere in Africa and anywhere in South Asia, including India, Pakistan, Bangladesh, Sri Lanka, etc. My other hat, and that's why Fahim has asked me to speak about this, is that I'm the TB lead for the region. And that, what I see, very sadly, is this TB seems to be returning with a vengeance. When I first came here in 1996, when I joined Royal Preston Hospital, the doctors were not too keen to be involved with management of TB. Then I was asked, and I took over the care, and then what happened was this TB incidence was low. But it started to go up again now. It had been high, it come down, and it's going up again. At that time, in the 1990s, it was a global emergency declared by WHO because a third of the human population, that is more than 2 billion, were infected by TB. And there were 10 million new cases annually. That's globally I'm talking about. What about now in the UK? Just in the last year, there's been a 13% increase. That's a massive increase because you're talking about in the UK, this is England alone, sorry, not the UK, 4,850 to 5,480. In the Northwest alone, there's an 11% increase. And the majority of TB occurs in people who have been born outside the UK. Notifications, however, in both the non-UK born and the UK born has been gradually increasing. But if you look at the UK born, 15% increase.
Any data on where they are born or where they live in the inner city or outer city?
Yes, where they are born was the main factor, but after that, living here, they tend to be, there's a higher incidence in London that's because of density rather than because they're living there. So, now, TB. People come to me very often and say, I can't have TB, I'm feeling quite well. TB is a great mimic. There's no such thing as this is TB, this is the classical figure. If you look at the X-ray, there are hundreds of different ways in which it presents. And in our mind, we think a patient at TB looks like this. Many people come to me to the clinic, and when I say that you've got TB or we suspect TB, they say, look, I'm very well, I can't have TB. I'm very clean, I'm very hygienic. I never had nobody in my family has had TB. We're all very clean. It's not a dirty disease, TB. Anybody can be affected by TB. I don't know if any of you know this personality.
50s star, I think.
Sorry?
The 1950s actress or something.
1950s actress. Well, must be Dr. Shakur's favorite at that time. What is she called, Taslim bhai? You're right though. This is Vivian Lee from Gone with the Wind.
I see what I
So people thought she's very slim and pretty in that time, but actually she had TB. So, it's not about being from a particular part of the world. I see a number of people from all over the world with TB. Do you know who this is?
No, this is what I think.
John Keats. Fahim, you read in school about John Keats?
Yes, of course.
Okay. Jew people, the answer, the take-home message is that more than 95% of patients with TB can be treated completely. There are very few medical conditions where you can aim and hope and be certain about more than 95% cure. That is what TB is today.
I wish Devdas was born today.
In terms of years of good quality human life, treatment of tuberculosis is amongst the most cost-effective of all therapeutic interventions. But despite that, people are dying. It is still one of the biggest killers. In the 1950s and 60s, all you had, this is Papworth Hospital in Cambridge. They could not treat TB very well. So these are chalets. They were put in the chalets because they don't cross-infect, and people waited for them to recover or pass away. But now, how many months treatment do you give for TB?
6 months.
6 months, absolutely. 6 months all the time, except if there are complications such as CNS TB. That is, the brain is affected, nervous system is affected.
They're not isolated, are they segregated?
So pulmonary TB, where somebody is coughing and bringing up phlegm, for the first 2 weeks they can be very infectious. So they'll have to be away from others. Don't have to be in a hospital. Now, one caveat though. Remember, I said more than 95% cure, but the problem is if somebody smokes or drinks alcohol whilst on treatment, that cure rate drops, or takes drugs or any sort of abuse, cure rate drops. People used to smoke those days thinking like to be slim. They didn't realize that many of those patients had TB. TB, sadly, even today, despite everything that I've said, remains the captain of all the men of death. Why? Because it's still considered a poor man's disease. So with asthma or diabetes or any other condition, there are lots of research, billions being pumped into research. But a poor man's disease, in poor countries, there's very little investment. People don't want to be involved in the treatment of TB, worried about infections. I have my own experience. When I came here, people did not want to take the lead about treating TB. So, to conclude then, I have given you a few points about lung cancer, smoking, shisha, vaping, lung cancer screening, and tuberculosis. I leave you with this thought. Live sensibly. Among 1,000 people, only one dies a natural death. The rest succumb to irrational modes of living. A powerful statement from Maimonides ages ago. Thank you very much for your attention.
Are you okay to take some questions, Professor Manora? Would that be okay? Excellent. Question.
The boss, which is funny.
You know, they're a very well-educated crowd, as you know. They ask very insightful questions. Danny, question from yourself.
Right, thank you so much for that insightful talk. I have 2 questions. The first one is, considering the fact that sometimes people who have TB may not present with the cough that we, talk about in terms of pulmonary TB, and may have other forms of TB, what would it be like for us maybe in the primary care who are seeing patients like this who will probably think, is that COPD? Is there some respiratory bronchitis? Is there this going on? At what point do you think we need to perhaps maybe refer on or do that tests to make sure that we're identifying them as TB? Should we have a lower threshold? That's the first question. Second one is a little bit more, and you might have mentioned it, apologies, I was worried about parking, so I had to shift my car. So shisha, that's a very interesting concept because we know that in certain places we have like a shisha park and the restaurant right next to each other and passive smoking and all that. What are some of the, in terms of recommendations you could give for those who may know someone who uses it or who vapes, and that would help us educate them so that they stop or reduce in some way? Thank you.
Excellent question. So first of all, to do with, incidence prevalence of TB in terms of primary care and how we pick that up, any diagnostic help, in terms of the gambit of things that it can actually be. It's a great pretender, a bit like SLE. And also moving on, how can we stop people using shisha and vaping as well? Yeah, really good questions.
Good questions. And, when I first came to Preston, Fahim was this big. So that's the reason he's repeating the question. He thinks I'm so old that I won't remember. Thank you, Fahim. I'm only joking. No, first is a very relevant question. The thing about TB is you need to maintain, I did not put that slide. In all my TB talks, I put a slide saying the key is to maintain a high index of suspicion. Remember that TB is one condition. I've said about it being completely curable, but more importantly is the fact that it has community implications. I still distinctly remember in 1999, when I did my first started job as a consultant here, I saw a patient in the morning who came in, bit of cough, and then for 3 months, GP was thinking at that time whether to refer or not. Saw the patient, cough, phlegm. I did not let her go home. Took a sample of phlegm, told my nurse, we were having a clinic in Sharrow Green, rushed it, rang the microbiologist and got it examined. The smear was positive for TB. Why? Why did I do that? Because she was a dinner lady in a primary school. You see the primary public health implication. You're not treating only the patient. You have to think of the wider public. TB is, we have a team, not in the hospital alone, with the community. So that's the first answer to the question. Maintain a high index of suspicion. When in doubt, get the phlegm tested. Get anything else tested, because like you said, TB affects the entire body. I see patients with TB in the brain, TB in the kidney, TB in the bones only. And they feel quite well. And they tell us, particularly people who are not that educated, older people who've come from abroad, they often challenge me saying, how come you're saying I've got TB? I'm feeling well. So that's the first thing. Second thing about a shisha. Now, shisha is a bit of a controversial issue, contentious issue. The reason for that is it's early days and we do not have hard data, but all the scientific evidence that's coming through, I've presented one paper, all of it suggests that there are contaminants, there are chemicals, there are dangerous chemicals, there are all sorts of potential dangers of shisha, including carcinogens. So everything points in the direction of another problem just like smoking in the future. But not having done a study myself or not having seen those sort of randomized or case control type of studies over the years, we cannot present the same in the same emphatic fashion as we do for smoking, but it's heading that way. So many years ago we did a little project and we see how shisha has increased, and it's a dangerous trend. Worries me greatly.
Is there any other questions? Yeah, Talib, yeah. Question for Professor Munafa.
Do we need a better public health response to prevent TB? For example, better ventilation in public buildings, community spaces? Yeah,
so a public health question really on what we can do.
I was waiting for you to repeat the question. No. Honestly, we work in close collaboration with public health. You may not know this. Behind the scene, a lot goes on because sadly, some patients that we treat, most patients with TB are very compliant. We actually, when we start treatment, there are a few things that we do. I see the patient, commence treatment, do the diagnosis, and start treatment. But simultaneously, our specialist nurse, TB specialist nurse, she sees a patient as well to monitor them. But also, community TB nurses visit the patient at home to monitor them and then trigger a whole contact tracing exercise. Then we work with the public health department. Now, primary public health department, the problem is that TB is if you're living in a crowded environment, if somebody is coughing, you need actually exposure for several hours before you actually pass on TB. So in close collaboration, the passing on of TB occurs mainly in households. Or if you say we work in a call center in a very crowded environment, it may pass on. So it's more about raising awareness. If somebody gets a cough, a persistent cough, staying away from work till they're tested, those sort of environments. But yes, ventilation, anything else, it may also help.
So improving ventilation in homes and community spaces would be a way to...
Crowded spaces may help, but not as much as at home, and maintaining this high index of suspicion, catching them early, and also contact tracing. So we go and check whether somebody is already infected. We give them preventative therapy, which is called chemoprophylaxis for latent TB, not active TB. So we clear that possibility of that patient reactivating. Most of the TB actually, most of us have had the infection when we were born. So I was born in India, so when I was born there and brought up at the early years, you've got infected. Many patients tell me, I've not been exposed to, I've not been anywhere, I've not been exposed, I've not been to India, I've not been to high endemic areas of high endemicity. But actually, the reality is many of us have got latent TB. And that reactivates. The reactivation is the main cause of active TB.
Great, we're out of time now. Thank you again. Can we get an applause for Professor Munawar? Thank you. Yeah, we don't have time, I'm afraid. Dr. Qazi, can I get you to come now? We have a very tight schedule. As I mentioned, we have a lot of consultants from Royal Preston.
Thank you, Dr. Fahim, and thank you for arranging this educational session. It's great to be here. So, my name is Dr. Qazi. I'm a consultant in diabetes, and initially I wanted to make the focus of my talk really regarding, in a more positive frame of mind, regarding how we can prevent and how we can treat, and perhaps use a community approach to be proactive in managing type 2 diabetes. But I think before I do that, I think it's important for us to all have a reminder about diabetes and why we should take the problem seriously. So if I told you, and I might be biased, that diabetes is one of the most common, challenging, most complex, devastating chronic health conditions that is affecting our community right now, I wouldn't be underestimating that. So just to give you some context, do any of you know how many people in this country have diabetes? Can any of you hazard a guess as to what that figure looks like? Because it keeps changing by the minute.
I'm going to guess 4 million people.
Okay, and I think you'd be very close. It's estimated. So these are Diabetes UK figures. It's estimated that 5.6 million people in this country have diabetes. How that's broken down is the fact that we think that at the moment there are 4.3 million people who have actually been diagnosed with diabetes, and there are 1.3 million people who have diabetes but yet they don't know it, so they're undiagnosed. And if we add to that people who are what we call pre-diabetes or at risk of diabetes, if you combine the whole total, it adds up to 12.3 million people. So if you think of how many people live in this UK, it's a lot of people, and it wouldn't come as a surprise to you how much resources the NHS is using. Well over 10% of our budget for NHS really on diabetes and its complications. And what's worrying now compared to treating patients with diabetes, say 20 years ago, unfortunately the disease has become rampant in patients who are under the age of 40, and particularly our children and adolescents, where the incidence of diabetes is growing year on year. So there's been a 75% increase in patients having type 2 diabetes who are the age between 18 and 40, and that has really become prevalent. And the thing is that the diabetes does not distinguish between race, color, and creed, and it's unfortunate that, or in a way, you can think of it in another way, the fact that it affects our communities more, particularly those who come from a South Asian background or Afro-Caribbean background, and it's one of those problems that I think it requires us to have a different approach to management of diabetes. And I know in our community, it's almost like diabetes is a condition that's been normalized. Like everyone we know virtually has got diabetes, and we treat it as a condition that's all. We just accept it the way it is. But the sad fact of it is that in all of this, the outcomes for patients with diabetes is not good at all. So you've had talks about heart disease, and unfortunately diabetes is that condition whereby it causes a reduction in our life expectancy because we die earlier because of heart disease and kidney disease. And just to put some context, and I said that I would make it a more positive talk, but this will be the only morbid thing that I would say, is that if you're at the age of say you're in your mid-40s and you've been diagnosed with diabetes, you either smoke or you already have a heart condition. We are talking about a reduction in life expectancy. We all have to go and leave this world one day, of 20 years or more. So if I'm a carer and if I'm a parent, I'm looking at this and I'm really sort of finding this news difficult to digest. So it's something that we have to do, and we should start right from the youngest age and try to educate people about diabetes, how we can recognize the signs and symptoms, and how we could go about treating it. Because the positive message in all of this is that we can treat it. We can put type 2 diabetes into remission, and I'll kind of go through how we go about doing that. So First of all, does anyone know what could be the signs and symptoms that could be consistent with diabetes? Yes? Yes, yes. So those are the common symptoms that you described. So feeling tired, feeling lethargic, going to the toilet frequently, feeling thirsty, losing weight, finding that you have a wound that's very difficult to heal, for example. It could be another sign that you could have diabetes. But you know, quite a lot of the time I told you that 1.3 million people have undiagnosed diabetes. And what I'm trying to sort of convey from that is not because people are having these symptoms and not going to the doctors to get a blood test to check it out. It's actually quite a lot of the time patients don't have much in the way of symptoms, and it only comes as a surprise to them when they attend to their doctors for some other problem, another condition, and the diabetes is diagnosed there, or God forbid coming to hospital with a heart attack or stroke and then discover that they have got diabetes. So just to bear in mind that the government hasn't introduced any kind of national screening program for diabetes, which is distinct from, you know, screening for, say, lung cancer or screening for other conditions. But surely, if there's a high risk of having diabetes, say, for example, you had diabetes during pregnancy, or any of your family members have got diabetes, or if you're at a particular weight in which you'd be at risk of diabetes, these are all indications to go and get a blood test done. And it's a very simple procedure that involves just checking a blood test called the HbA1c. And Dr. Irfan mentioned about what numbers should be important to you. So if you have diabetes, your HbA1c will be 48 or more. That's how diabetes is diagnosed. And if it's between 42 and 47, then it is called pre-diabetes. So the first step is to get a blood test if you're not sure whether or not you've got diabetes. And most GPs I know would be quite happy knowing the kind of background that in terms of our demographics to get those blood tests done. The next question is then now that if I'm at risk of having diabetes, what should I be doing? I think if you're in this category, there's a very simple message here, is that there is a good chance, and this is where we either heed the advice or we don't heed the advice, that we can actually prevent ourselves from getting diabetes. Why? There are various programs that are available to people like people who need help and support in terms of the National Diabetes Prevention Program. So this is basically a kind of an educational stroke, diet and lifestyle education to try to prevent you getting diabetes, and you'll learn about the fact of how you can make changes to your diet that can help. For example, reducing our dependence on carbohydrates, eating a balanced diet where we also get our calories from protein intake and fat, and also take regular exercise. All of these things have been shown and proven to be actually beneficial in preventing getting diabetes in the first place, or delaying it for taking longer. And if you are in that category, then I would strongly suggest that you take that opportunity, because the time from being diagnosed from pre-diabetes to diabetes could invariably be very, very short. And so there's that opportunity to make sure that one doesn't get and develop diabetes. If you do have that result come back and it's showing that you have a HbA1c of 48, again, this is another opportunity whereby there's lots that we can do that can help. Again, the same principle of having a healthier lifestyle and diet does help. And we know that, for example, weight loss, even if it's to 10 to 15%, can actually help put your diabetes into remission. And there are various other ways that do not involve taking medications, because that's what people get afraid of. Does that mean I'm going to need to take medication for the rest of my life? Does that mean I'm going to take insulin? But you can do it by achieving that through diet and lifestyle measures alone. And there are evidence to suggest that having diet that is more rich in, for example, plant-based stuff and fiber-based foods that can help to improve gut health, which is one of the kind of major determining factors in terms of developing insulin resistance or reducing insulin resistance, which is one of the key kind of mechanisms by which we get type 2 diabetes. So lifestyle measures will certainly help, and there's been tremendous success in that. And some people actually do find that, for example, going on intermittent fasting is another way of being very, very successful strategy in trying to help control blood sugars. Okay, so that, again, I would say that this is very much something that's easier said than done, but something that I would suggest as a community and with us, within our families, particularly the people that we look after, that we make sure that we don't lose that sort of important element of diabetes management. It's always said, it's always glossed over when it comes to you see the GP. They very quickly focus on medication, but that is really the cornerstone of treatment. Then in terms of treatment options, there are many treatment options that are available for diabetes that your doctor, your nurse will talk to you about. They tend to kind of focus on trying to help the body reduce the blood glucose levels, but one of the big dangers of diabetes is not so much what the effects of the blood glucose levels are on various organs of the body, it's the fact that what diabetes does, unfortunately, to your heart and to your kidneys. So it's one of the leading causes of heart disease and kidney failure in this country. And we do now, with better understanding of science, particularly in managing diabetes, we do now have very promising treatments that are available that are designed not just to reduce your blood sugars, but also reduce your risk of your developing kidney disease and heart disease. And it should be a cornerstone of management that your doctor more likely will be putting you on one of those treatments, because it's designed to help you live longer and to reduce the complications of your diabetes. We also now have treatments that involve taking injections, and you will have heard it, of injections that are being used to try to combat obesity. But these injections were first introduced into the treatment to manage patients with type 2 diabetes, to kind of help their body regulate the blood glucose levels, and also to kind of sort of suppress the appetite, which was one of the reasons why diabetes progression got increased in the first place. So do talk to your doctor about what other treatment options are, and keep focused on what your HbA1c result at the end of the day, because there is a saying that if you look after your diabetes will look after you. So that number of 48 becomes one of the numbers that you kind of have to use as your kind of way of talking to your doctor, your nurse about your diabetes, is what are we doing, as in the combined approach as to how are we going to help achieve that target. And if we achieve that target, there are a number of benefits. So if you're starting at a level of 58 and you want to get down to 48, you'll give yourself a tremendous favor in terms of trying to reduce the complications of diabetes. And it's one where I think I should pose the question to you guys as to, we know that diabetes is a challenge, it's not going to go away, but how are we, in terms of what do we do in our society, in our communities, what can we do in our communities to try to beat diabetes? Because you will see that diabetes is ravaging most communities, unfortunately taking away our loved ones a lot sooner than they should have gone. And I think it's for us to determine where we should now fight diabetes. But just to say that it's not, it is something that is very much within our gift. It's how we choose to go about trying to treat that condition. So I just wanted to kind of emphasize that message and get all of you involved in trying to think of ways in which we can help combat diabetes.
Can statins increase your blood glucose levels?
So most of the scientific fraternity of the opinion that statins do not cause diabetes. So in that regard, we generally tend to feel is that the statins are very important in the management of diabetes, and in our ambition to try and control blood glucose levels. I think the idea that statin cause diabetes is very much being hyped up.
In terms of the South Asian diet, is there certain things that you can advise, just in terms of what we need to be aware of?
Sure. I think traditionally in our South Asian diet, we just judging by the treats that are out today, that we are very, very liking our carbs. And I think the one simple message could be is consider the amount of carbohydrates you're taking, and maybe substitute the excess amount of carbohydrates and swap it for things like protein, which would be a much better way of reducing the insulin resistance. Yeah.
And can you slim your way out of diabetes, would you say, if you've already got a diagnosis? Is significant weight loss, is it enough to reverse it?
Yes. A lot of studies have shown that a reduction in weight of 10% or even 15% from your baseline does it. Now, there's several ways that you can do it. There is the type 2 diabetes remission program, which your GP can put you on, which involves really taking a year's worth of diet, which is effectively soups and shakes. I think everybody would agree that this would be a very difficult thing to sustain, but certainly reduction in amount of carbohydrates, reduction in number of calories, and increasing your level of physical exercise is as good in terms of maintaining that and helping to maintain remission. So dietary changes are most important, I think.
How far are we away from stem cell route to the pancreas? To cure
Okay.
disease?
So the treatment of diabetes has become advanced, but the stem cell or the pancreatic transplant therapy that you're talking about is more useful in a scenario whereby you have type 1 diabetes, whereby your pancreas does not produce insulin. And having a stem cell transplant or having a pancreas transplant would actually mean that you would effectively cure diabetes. Type 2 diabetes is much more of a different scenario whereby your body is able to produce insulin, it's just not working effectively, just not getting where it needs to. And in this scenario, there's plenty of evidence to suggest that even dietary and lifestyle measures alongside medication can help. But if we can get type 2 diabetes into remission, we would actually be doing all ourselves a big favor, because unfortunately we know that a lot of patients with diabetes unfortunately die a lot early because of heart disease, stroke, and kidney failure.
Is there a estimate that there might be an increased incidence of type 1 diabetes amongst very young children, less than 5 years old? Is that the case? And what might be the reason?
I think the incidence of type 1 diabetes has stayed relatively static. That hasn't really changed much. Type 1 diabetes is thought to be kind of an autoimmune disease. And over the last 10 to 20 years, the number of patients getting type 1 diabetes really hasn't changed much at all, even in younger patients, even in children. So type 1 diabetes is probably still the most common cause of diabetes in young children. However, we are now seeing type 2 diabetes in ages of 5, 6, 7, 8, and that kind of age group, and that is the most concerning. And inevitably, one has to put it down to the nature of lifestyle, particularly the type of food that we're eating that's contributing to that, and particularly the element of obesity, which is affecting that group of population. So I think it's more about how do we start young in terms of how to educate our children about the importance of having a balanced diet and taking regular exercise. It's a big problem now.
Recently, Manjura injection was quite popular to reduce the weight in diabetic patient and reduce the insulin resistance as well. Just wondering, I think the doctors, they gradually increase the dose. How long they can take to increase the dose of diabetes?
Okay, so there is a question about Mounjaro, particularly to use in patients with type 2 diabetes. There's also the question about what to do with Mounjaro if you don't have type 2 diabetes and you're managing it purely just kind of for weight management purposes. So if you have uncontrolled your diabetes and your doctor determines that Mounjaro is the best treatment for you, it's a weekly injection, they would be happy to give it to you as long as they know that the diabetes is under control. Because the drug in most patients works effectively, usually you do not need to have too much of a high dose. So once your blood tests confirm that your diabetes is now well controlled or even in the non-diabetes range, your doctor would not be inclined to increase the dose even though you made a good response and you made a good weight loss response. With Manjaro, there is no set time where you can only be on it for a minimum amount of time. Your doctor will keep you on it as long as he feels that you do not need it. And that question may arise when you've lost that significant weight, and your doctor will say, well, actually, have you thought about now coming off these medications because you've now gone into remission? If you're talking about the management of weight management because you still want to lose that weight because you have the excess weight, that is a different situation altogether. And unfortunately, the access to medications such as Manjaro, in that instance on the NHS, is extremely restricted right now. But there is no essentially limit in terms of how long you can be on it. Only that with medications such as Manjaro or Wegovy, it is thought that once you do stop it or you decide you slowly want to come off it, then there is a chance that some of the weight that you've lost will come back on, which emphasizes the whole idea of trying to manage with diet and lifestyle as best as you can, because that's ultimately, it's about behavior change. Thank you. Thank you.
Thank you. I'll take that. Thanks. Just give everybody a 5-minute break. I'll find out.
To mount this somewhere. Can I do that?
What do you do?
I'm going to record myself as well.
Yeah.
Can I let you...
You give Chanika.
You're amazing. I love you.
Okay.
Yes, please.
Okay.
You can mount it if it's easier. He was like my background dancer. Oh. Okay. Hello. You made it. Okay. I'm going to start with a story. It was a Friday night. I'm sat on the sofa. We're sat on the sofa. And I've had a long week. Watching Irritable, probably, at the time. The classic Turkish drama, you know the deal, pretending to know what the words mean. We're sat there watching TV, and I get the dreaded Friday night question. Seema, what we're going to eat? And I'm like, oh, God, that question, I hate it. It's all right. I'm saying the same thing every week. It's okay, whatever you fancy, it's okay. We'll just eat whatever you want. No worries. Same thing next week, Friday night, and I get the same dreaded question, same response from Seema. We'll eat whatever, you decide. The next week, he asks me, Seema, what are we going to eat? I feel like you don't even know what you want to eat. Do you even know what you like? And it knocked me for 6. Because in that moment, I realised that I am a bit of a problem in that relationship. I was hiding behind the good person persona, but actually it was blocking me from actually knowing what I even wanted or liked. And whilst it sounds like a really noble, good thing to have and be, underneath, I'm recognizing that it's building like this internal resentment for my partner. It's a quiet, silent little resentment that's growing over time that I'm pointing outwards. And I know many of us ask this question of, does he really understand me? Does she really see me? Am I really seen in my relationship? Do they really know what I like, what I want? And oftentimes we look for that question pointing outwards, but really, is it about the other person, or is it that we are just not allowing ourselves to truly want and hiding it under the guise of being the good person? Especially in our South Asian Muslim culture, it can be the case we've been conditioned, a lot of us have been conditioned to sacrifice a lot of ourselves for the betterment of other people, which puts everybody else's priorities and everybody else's wants above our own, and we come at the bottom. This can be a massive issue and can slowly corrode at your relationships. Just wanted to start with that story because I know some of you can relate. I'm going to introduce myself again. I'm Seema Mind, as was mentioned earlier. I'm Seema Mind. I am a life coach. I help people across the world work on their relationships, creating relationships they want, and a life that they want using their brain and their thoughts and their beliefs. If you do have any questions whilst I'm talking, please make sure to hold them, keep them in your pocket, and then bring them to me after I've finished. I'd love to hear your questions, and I will be sticking around, so that if you have anything personal, anything you want to share, feel free to come along and stop me for that. I don't know about you guys, but I don't leave my front door open wide to let anybody in. I imagine most of you don't do the same thing. If anyone does, that's a different issue. We should probably talk about a different way to deal with your mindset there. But I don't leave my front door open to my house without it being locked and it wide open. And the reason is, that's my safe place. My house is my safe place. I like to stay there, and it's my place of comfort. I wouldn't just let anybody come into my safe space and take my food and sit where they want to. I don't know how unsafe I could feel. But yet, so many of us might keep our doors locked and keep our front door closed. But when it comes to our own emotional health and our emotional safety, that door is wide open. In our romantic relationships, in our friendships, even with family. Most of us haven't been taught how to set boundaries. It's not something our parents sit us down to learn, and it's not something that we learn about in school. We don't really get them. A lot of people think that setting a boundary is having an expectation. And this is another way that I want you to consider about how we protect and look after ourselves in order to look after the people that we love. There's a really famous quote by a man called Jim Rohn, one of my favorite quotes, and it's something like, "I'll look after me for you if you look after you for me." A lot of us forget that whilst we think we're doing all these lovely things for other people and letting them have what they want, it is actually impacting our well-being within us as well. Our mental health, even our physical health, especially with women as well. This can be a really big stickler for us as girls. So when it comes to setting boundaries, I want you to think about this. It's a way of making sure the good inside you is staying good and not getting filtered and tarnished with the muck. Right? You're protecting the safe loveliness that is within yourself, okay? A boundary is not an expectation. So it's not, oh, I want you to be happy around me all the time. It's a way to protect yourself from when you are feeling emotionally or physically unsafe. But it isn't something you want to approach in the heat of an argument. So I'll give you an example. When I was with my husband at the time, and we're in the heat of an argument, and I know what's going to happen. Classic Seema. She's going to see him sweating and raising his voice slowly, gradually. He's getting really stern. And then I'm going to get stern too. And then it's all going to be all loud and stern. And we're both going to make no progress and just be annoyed at each other. You know the deal. I don't want that anymore. So I learn how to set boundaries, and I make sure that I commit to that boundary. Now, I know setting a boundary does not happen in the heat of that moment. He's emotionally unsafe if he's having to raise his voice, and I am too. That is not a place where we can have an understanding conversation or make a deal. But when we're sat on our evening cup of tea, and sat by the sofa, on the sofa, and having a chill and reflecting on our day, aramse, you know, the deal. Then I can talk about, you know, that argument we had. I didn't like how it went down. And I really like being in a good place with you. I'm sharing my feelings about what I like. I feel like we should work on a way to correct that. So, let's make a deal. When you and I are having a heated discussion or a discussion where we might be in disagreement, if you or I start to raise our voice or feel that voice rising, we get to leave for 5 or 10 minutes. If it's you that raises your voice and you want to leave, you can. If I raise my voice and you want to leave, you can. I give you permission. And the same back. If I raise my voice and I want to realize I'm doing it, I'm going to leave for 5 minutes. And you the same. If I realize you are, I might leave. But we both get to make that the same deal. We get to leave. Every time, we both were in agreement. Every time after that, if ever we got into any sort of collision, any sort of disagreement, immediately I would notice when my voice is getting a bit louder than usual, and it will go back to normal. And the same would happen to him. Every time I know, like, it's heating up now, and he would take a breath and just stop and talk to me. Because we've made a deal, and we made that deal when we were in an understanding. We made a commitment in that understanding, not in the heat of the moment, but it was upon reflection. When you are setting a boundary, you are stating when that boundary is going to be set and what you will do about it. In that scenario, I gave him permission to leave and I did, but when you are setting a boundary, it is not about telling other people what to do, it is about what you are going to commit to do when that boundary is crossed. That emotional unsafety. You decide. And the hardest part, which most people struggle with when setting a boundary, is locking that door, closing that door. It's committing to what you said you will do. It's not a false promise, it's not a threat. It's committing to what you said you're going to do. So I will leave. Bus, that's it. That's the only thing. And committing to it. Leaving. The next thing I wanted to share with you was about how to make sure that we are looking after our own emotional well-being and not passing over the responsibility. A lot of us do this. Our brains are wired to not want to feel bad. So we want to feel good, of course, but we don't want to own it. If we are the cause of bad, our brain doesn't want us to feel like that, right? So we're going to outsource this responsibility oftentimes. And I want you to understand this one really important concept. If you don't take anything away from this chat, please take this. And it can be a harsh reality. Nobody can make you feel a certain way. You are experiencing a feeling within yourself. You make the choice to have that emotion. And I'm not saying it's a good or bad thing to feel bad either. You're supposed to sometimes feel bad. If you didn't feel bad about death, you'd be a psychopath, essentially. It is okay to feel good, it is okay to feel bad, but know that that is your emotion. Most people come to me and they think that emotions are in the brain. They are not. Your thoughts happen in your mind. Your feelings happen in your body. They are stored sometimes even in our body. But pretty much everything neck down is where our feelings happen. And I'm just going to touch on this just briefly. I was speaking earlier to Professor Shakura about prayer and salah and namaz. And I just want to touch on this because I know the crowd is here, mostly a lot of Muslim people here. There's something really important for us to recognize, that even in that movement that we do 5 times a day, or try to, wherever we are in our journey, there is a lot of ability to release some of those emotions, and we should really max out on that. Because if there's stored traumas, which often happen in our hips, which we hold a lot of trauma from our history, from our lives, within our hip area, then even prostrating and moving those hip flexors around can help release that emotion. Which is why sometimes if you're in sajda or ruku, you might feel like you are maybe even teary, or a bit additionally emotional. And there's so much science behind that. There's so much interaction with our body, and that's why we're advised to, for that reason, to help us release that. So just a little tidbit for you guys there. But going back to my point, learning how to feel in our day-to-day lives is a really important thing for us to know. And it's really weird how to feel. It seems like the most obvious natural thing to do, but actually most of us don't know how to. because we actually think it happens in our brain, a lot of us. We think it's happening in our mind, and it's actually in our body. So I do this with adults and I do it with kids, but I want you guys just to take it on. If you have children, use it in your car journey home, from school, whatever. But it's, number one, naming the emotion. What am I feeling? And this is a really good time to learn different words. If you speak two different languages, mix it up. I know in some languages we don't have that many emotional words. We could do with increasing our emotional vocabulary, but where you can, try and be really specific. It's not I feel good and bad. It's I feel like I'm in a low mood, or I'm feeling really excited, or I'm feeling depressive, or I'm feeling anxiety. Whatever the emotion is, allow for the words for it. Try and be really specific with what that emotion might be. Even if it's to yourself, even if you're just trying to, you're feeling something, you're not really understanding what's going on, just remind yourself, give that word. Then the second thing, I want you to locate where that emotion is. I don't know if you guys, I'm sure some of the doctors will probably agree with me on this one, but a lot of people who have anger issues, generally, it's a big generalization, and please don't shoot me, doctors, for this, but a lot of people who have anger issues tend to have heart issues or blood-related issues, because a lot of anger, it rises higher up in the body, around the chest area, sometimes into the shoulder, even moves into the fist. Anger rises, and a lot of it can be held around this chest area. Same with heartbreak. It's actually around that chest area. Anxiety, for example, can be around the torso and the belly. So especially around COVID, I'll give you the example. The reason I make these generalizations, and I'm so sorry, is because around COVID, I used to have a lot of clients who were doctors, who would come to me and share to me.
Okay, if you don't mind.
That's fine, not a problem. Around COVID, I had a lot of doctors who came to me with certain issues, and they just wanted to have a safe place to talk. And then in passing, they would tell me, "Oh, you know what? I've also got IBS, but I've got the medication for that. And anyway, this is what's happening in my life, and this is what's happening in the hospital, and I'm going into work, and I'm really stressed out. It's scary. Blah 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 blah. All this story around what is happening with COVID. It was a scary time. But thinking that the IBS was a background thing, when actually a lot of our emotions are happening in our body, and a lot of anxiety is happening around that torso area where a lot of digestion is happening, and it's actually impacting that gut health, that digestion as well, not realizing the two are related. So it's really important for us to recognize that if we're having a feeling, to acknowledge it means it can be released, because an emotion is actually a vibration. A feeling is actually a vibration in your body. It's like, when you're sat and you're a little bit anxious or nervous, I'm not going to sit because I don't want to break the table. But if you're tapping your foot like this and you're ready to go, it's because you're anxious about something. The anxiety sort of moved into your leg. Lots of people do it when they're ready to go to the next thing. They're tapping their foot away. Lots of different behaviors that can move into our body, and it's because of the fact that the emotion is a vibration and it's happening somewhere within your body. It is moving in your body. So you want to, number one, name it. Number two, find and locate it. And this is another thing that I do with children, especially if you're a parent, please acknowledge this one. Maybe give it a colour or a shape or both. Sometimes we work on heat. So is it a cold feeling? Like if you've got your kids in the back of the car, what does, Mummy, I was happy at work. Daddy, I was at school, sorry. Daddy, I was angry today. What does anger look like? What colour is anger? Is it hot or is it cold? Is it, if you were to say it was a shape, what shape is anger? Is it pointy? Is it in your head? Where is it in your body? Exploring that emotion makes you, even for yourself, do it. But even if it's with children, it makes the child recognize that they are not the emotion. The emotion is an experience, and it passes and changes, and it can. This is why a lot of people, will label themselves and become very engrossed in the emotion that they might describe themselves to be. It's not I'm angry, it's I have the feeling of anger. I am feeling angry. You don't want to make it your identity. The same way you might say I'm a man, I'm a woman, I'm a doctor, whatever it is you might identify. You also don't want to identify as your emotion. So separating that experience helps you to recognize how to process it. Okay. The reason I want you to really take that on board is because it helps you to not point the finger. Again, if you know that somebody is winding you up and anger is rising, the first thing that will happen to me now, if ever anyone tries to trigger me, is I will observe, oh, Seema, you've got anger, it's rising inside you right now. And you know what you usually like when anger rises, this is what you do, and how does the situation end? Not too good. So maybe we'll switch the behavior this time. Or let's just say, hey, I'm feeling angry right now. I'm just going to take 5 minutes to cool off. And I can disconnect from it and let it process and react in a way that is more productive in my relationships, whoever they are with, right? Okay. How are we for time, people? Dr. Shakur? What time are we on? Oh, we got. He's enjoying his food. He's all good. Save me some, please. Okay, I'll just bring up a couple of things then. Another really big issue I see that happens in relationships is, again, this outsourcing, but it's done in a very subtle way. Again, very predominant in South Asian community. It's not actually accessing and fulfilling your own potential. So when you might want something deep inside you. You might actually want to have tried this new business idea, or you might have wanted to start this new class, or you might have wanted to go see your friends a bit more, or start a business, or study something, but you didn't, and you're not doing it because I'm a mom, right? I'm a parent, right? I'm a husband, I'm a wife, or I don't have the time. I don't this, that, the other. And whilst we can hide behind those excuses, because I promise you, if you tell me that excuse, I will probably find you an example of a client that has done it with 3 kids and looked after her mother-in-law and everything else, and still manages to make time for the gym and has a loving relationship. Yeah. So, if you are neglecting yourself in that way, or even not allowing yourself to want, that is something that can really massively impact your relationship and damage that bond between you, because you're constantly looking to blame it on other people. Oh, because my husband's this and my wife's this, and if you are not acknowledging that want that you might have, that fulfillment you might have for yourself, you will create little fractures in your relationship. And again, it's like the thing I was talking about earlier, like the people-pleasing thing. It's this internal resentment that tends to build over time. And the last one, which is, I think, the biggest conversation at the moment, probably societally around relationships, is the difference between men and women. We are different. Really, really different. Very different. Our brains are built differently. Men are not hairier women. So we don't always need to communicate with them like we think we need to communicate with our sisters and our girls. So ladies, that is something I want you to hear up. Gentlemen, I also want you to understand that you should really have more boy time. Spend more time with your men. You men get a lot from those male relationships. And that is something that you guys generally right now are neglecting a lot. And so you'll end up dumping a lot of your emotional traumas and your emotional baggage on your wives, and I don't want you to do that anymore because you don't need to. You should be maxing out on your male relationships. However, that's not to point fingers at you guys. The reality is we're all not taught that our humanness is actually very different. If anything, a lot of people are trying to make it as though we are the same. Our brains are not the same. Men's brains are very linear. Girls, this is something you need to hear. Men's brains are wired very front to back. So they're very goal-driven. So they will be really good at achieving certain things, getting results done, getting things done. And we love the guys for it. Thank you, guys, for this. Because we don't have that very linear. That's why when we go to the kitchen to get the fork, we also see the ketchup bottles open, and then there's also a plate on the side, and I forgot to turn the tap off, and this is that, and everything else you picked around the way. Not just one thing, like if you tell a guy to find something, he's just going to. He's just going to go get that one thing, and then he'll bring it back to you. Whereas us girls will have like 10 other things that's come along the way. Even in our conversations. I'm sorry, guys, I know it can get really annoying. This is why we go from one bit to the other thing, and then the other thing, and then the other thing, and you're like, what? Why did you tell me all of this stuff? Yeah, as women, we have brains that are wired like wire wool, a little bit more. Our neural connections are all around the brain. So, we have to understand how to communicate differently with the different genders. So yeah, that is something I want you to really keep in mind, because when you are losing focus in your conversation and it's annoying him, it's not that it's something personal, girls. It's actually just because we are wired differently. And that's okay, it's a beautiful thing, but we really must accept the difference between us. Guys, this is one thing us girls are really rubbish at telling you, and I'm going to tell on behalf of most of us ladies. We will switch between two modes oftentimes. We want to vent to you sometimes, and then we want solution sometimes. Sometimes women find release in just speaking and vocalizing their emotions. It's not that we want to hear you say, well, why don't you do this then? And why don't you try this then? Which is obvious. It seems like she's got a problem. You want to solve it. We love you for that. But as women, sometimes the only solution we actually need is to be heard. That is it. So, a really useful question for you men to ask if ever your lady friend, your sister, your mother is having this sort of conversation. You're like, I don't know what she wants from me right now. Does she want a solution? Does she just want to vent? Ask. I do it with my girlfriends sometimes even. Do you want soft seema, or do you want me to be the harsh seema? Do you want to vent, or do you want a solution? Right? Just identifying what your person might find useful is useful and helps you to navigate between the differences between men and women in those relationships. I can go on about this for days, and I'm happy to answer any questions if anyone has any. I know that I did say I would in your personal relationships. But yeah, thank you all for listening, and I hope you found that useful. If there is anything else that you wanted me to go over, let me know. There you go. Thank you.
Thank you so much. The last time I saw Seema was with the family at Agadir Croco Park. I'm glad we're both still alive. In Morocco, we both made it, so it's funny how the world's so small. That was a really interesting topic. Are there any questions on what's been raised there on relationships? Yeah, absolutely. There's someone at the front who wants to make a comment.
Two things. There's a lot of talk nowadays about attachment styles. Is there any basis in factoring that in? And secondly, how do you deal with hyper-independence in relationships?
I love that. Okay. Attachment styles and hyper-independence. Okay. Is there any basis? Do they exist? And is that what you're asking?
Yeah. Is it a factor we should be...
Yes, factoring into our relationships. I believe so. There is mixed opinions. However, I think that attachment styles really, knowing that about yourself is a really positive way to better our relationships. Okay, so for those who don't know, attachment styles, just to quickly generalize them, they're sort of made up of personal anxiety, So if you're an anxious attachment or a avoidant attachment style or a mixed, I'm just going to generalize here, or a mixed attachment style. Anxious attachment styles tend to be a bit of a chaser. They want to fix problems really quickly. So if they're in the middle of the fight, it's like, no, I want to talk about this right now. The avoidant is like, goes out, leaves the house, doesn't want to embrace that emotional conversation immediately. And knowing this about yourself, which one you might be, it's a very big generalization. And obviously, of course, if you have any questions or want to talk to me about it in more detail, please do afterwards. But
one question on the attachment bit.
Go on.
How we form attachments when we're younger, that's how we develop a relationship.
Yeah.
That's how we,
yeah.
like if you go back to like the attachment theory originally, that's how we navigate our relationships as we get older.
Yeah, 100%. And that's exactly what I was going to get to. Thank you for mentioning it. It's the fact that naturally our brains are wired for survival. Our brains want to keep us alive. That's the brain's primary job. Now, everything it's experienced as a child is what it absorbs as factual survival information. So for that reason, whenever we are modeled certain relationships around us, parents, caregivers, grandparents, that's what we tend to absorb. So what we absorb of the masculine, so as you might notice that if your father was a certain way, he was really passive, didn't really talk about stuff, then as a man, you might become that way. And as a woman, you might attract that from your partner. And even if, sometimes, if your partner wasn't like that before, you can shift to make them that way in certain subconscious behaviors. So we call them generational cycles, where we repeat certain behaviors that we've seen growing up, and that we end up, if we don't manage our brains, we can recreate them into our relationships. It's why a lot of women will have relationships where the partner actually is behaving a little bit like what they saw of their own dad, or vice versa, where you've kind of attracted a similar vibe to your mother as a man. It's because partly you have created that as well, because that was what was modeled to you. So that's where anxious and avoidant attachment styles, there's more to it, of course, but they do factor into relationships. You can 100%, I've seen it done, and I've done it myself, and I've worked with lots of people, create a secure attachment style within yourself. But the best and only way to do it is within your relationships. I truly, truly believe, and I can't reiterate this enough, especially for those of you who aren't in relationships, you can only heal relational wounds within your relationships, in my belief. So being out of them, whilst a lot of us glamorize the healing work, is a useful way to make sure you heal. I'm not saying don't do that either. However, if you then are trying to heal those relational wounds, practicing or learning how to be in one, or even allowing yourself the chance to be back out there, is really important. Because when you are trying to create a secure attachment style, that is where it's going to be tested. And the real way to create secure attachment style is to simplify it sounds so cliche, but is to create an ultimate self-love, self-respect, and self-trust within yourself. And I tell you, this is why we were talking about this earlier. I was speaking to somebody earlier about, people of faith. Oftentimes, they have when you have a greater power, they generally, when they have a greater belief, there is often a better well-being and a quicker way to feel better. And that's because of the fact that there's a self-trust almost, and a trust in something greater to always take care of us. So yeah, those things are really important and can create really secure attachments within us. Like I said, I don't want to go into it too much because there was another question. What was the second one? Please remind me.
Hyper-independence.
Hyper-independence. Hyper-independence with women or men or either?
I'm hyper-independent.
Okay, it was about you.
Okay. Amazing. I'm really glad you used yourself as an example. Threw yourself under the bus.
It's a strength and a weakness.
It's a strength and a weakness. It's a strength, and again, we love it when the masculine is able to take care of things. As women, we do. And if we don't show you enough appreciation about that, please take it from me. We just aren't gobby enough where it counts, okay? We just need to tell you more. We do appreciate that. However, if it is a hyper-independence, it's been conditioned because of a deeper core belief. I am not important or worthy if I don't constantly look after myself, or no one wants to help me. No one should help me, no one can help me. Along the way, along your journey, there would have been a time where that was easier to do than ask for help. Even if asking for help might be taught to you as a weakness. That can often be the case. I know even for me, oftentimes I felt like it was. And so my training was practice asking people for help. To the point of if I'm in a restaurant and the waiter hasn't opened the bottle of water for me, I will ask him if I can't open it. Rather than trying really hard and doing all the things, I now train on purpose. Even though I know, sometimes I even know I can do certain things. And yet, I'll train my nervous system to accept help. So if there is that hyper-independence, drop back. Do you mind helping me? Because you know, the truth is, sometimes you feel like the better person, the happier person for helping. Some people want to give you that help, and you're not letting them. You're taking that away from them. They want that ability to actually be there for you. And you're actually taking that away sometimes by not asking for the help. So where that hyper-independence is concerned, sometimes ask for it. People will be honored at times to be there for you.
Practice asking.
Practice asking. Just for stupid stuff. Just even start there and then build it up.
Cup of coffee, please.
That was an order.
I don't think that was asking. That's very instructive.
What other questions do you have? Hello. What would you like to say?
I wanted to say anger is red.
Anger is red?
Yeah.
You know, I think anger is red too. Sometimes I get anger in my face, and it makes my face red. Does your face ever get red when you're angry? Have you never seen in the mirror? I feel like when anger is red, it makes my face red. Thank you for sharing that. Does anybody else feel red when they're angry? So many people. So many people. Thank you for sharing that. I think you helped everybody else share as well.
I'm really not.
Sorry about that.
No, thank you.
Yeah.
Is this okay now?
Yeah, that's fine. Yeah, now it's working. Sorry about that. Like your woman's body is usually changed during the pregnancy, and quite a lot of hormones released from the body, and which is the necessary to women know about it and just go for and ask for the more details, because every bit of pregnancy needs help. And mostly women, I noticed during the research, they ignoring. They said, that's fine, I'm pregnant, yeah, and just getting care from the midwives. Yes, you are getting care from the midwives, but you need to know about yourself because more education is needed. Also, early pregnancy, checks. You are going every time with the midwives before and after the 10 weeks of pregnancy for blood tests, for sugar tests, for ultrasound, and you're taking the vitamins as well. But before you go, and just discuss which vitamins is more crucial, important for your pregnancy, because some women just taking over-the-counter vitamins, which is sometimes is harmful. But you need to make sure you are eating right vitamins and taking right vitamins for yourself. Okay. And yes, I would like to discuss about the healthy pregnancy habits. Healthy pregnancy habits means eat fresh fruit and balanced foods. Fresh fruits and balanced food means exactly what is the you are eating. You need to know. Don't search by internet and social media. Sometimes it's misunderstanding which food they are eating, which food is good for. Ask your health provider, which is more important to get support through the NHS, not get support through the Google. And drink more water, as you know, rehydrate yourself during pregnancy. And what should you avoid? Obviously, alcohol, smoking is not good for health. Yeah, thank you. Not good for health. And this too much caffeine is also harmful for baby. And you need to look after yourself, because baby doesn't want more caffeine like we need. More caffeine, raw eggs, unpasteurized milk, and medication. Sometimes you need to know about which medication is suitable for you. Just go with your health provider. I will insist this, because women sometimes they do, I can take paracetamol, I can take ibuprofen. This is fine in a pregnancy. No, I can say asking with your health provider and midwives is more important. The next thing is emotional well-being, emotional stress. Sometimes women, they get more stress, more problem, and they are not getting support because they think it will be fine. This is the pregnancy, hormone releasing, and that's it. But they can affect your baby. And your baby doesn't want to stress. Obviously, they want healthy mom, because sometimes what happens, if the mothers are there getting too much stress, then what happens, some certain of hormones release from the body, which gives the mother stress, and also mother get annoyed and try to reduce the food. Also, mothers is struggling with some symptoms, which is like vomiting, sickness, and also on top of this, you're getting stress. And reduce your diet, reduce your vitamins, reduce your health and well-being, and this is affecting your body as well. Your body and your baby's body. Yeah. The common pregnancy symptoms, as you know, the backache, vomiting, headaches, swelling of it. People, they think it's normal, but sometimes I can say, if you get these symptoms and you are not relieving these symptoms, you need to speak with the doctor, because some headaches is very harmful. Means you are struggling with your hypertension, and hypertension in pregnancy is really harmful for you and your baby's health. And that's why I just bring this topic, because my specialty is preeclampsia. Hypertension in pregnancy I did not include it here, but it's more than 50,000 children each year just death all over the world. It's quite like high neonatal deaths around the world. And you need to look after your baby. And that's why you need to speak with the doctor if you are getting this kind of symptoms like headaches, blurred vision, can't see properly, it's like dizzy, and tummy ache, sometimes pain under the ribs. You're feeling, it's tummy ache because of maybe my pregnancy. But no, I can say speak to a doctor or go emergency triage, because it's really important early treatment of hypertension in pregnancy. Otherwise, you and your baby get really harmful effect. And sometimes stillbirth means baby can die during the pregnancy. And unfortunately, still there is no treatment for this, preeclampsia. Just only symptomatic treatment, which is like you get the medication for your hypertension, and that's it. And some women think why should I take this medication, because this is not important, or maybe this my reading is fine, this is my blood pressure is fine, only the one reading came. And they, even though they are checking their blood pressure during the, home, but they think, oh, this is not important. But I think, I insist on this one, keep eye on your warning signs, and like severe headache, blurred vision, flashing lights in your eye, and pain under the ribs, sudden swelling and face on hand, and also to check your baby movement as well. And the next thing, the preparing for birth, the birth plan is more important. Discuss your midwife or your doctor or healthcare provider and make your hospital bank. And support for feeding your baby is very important. Just ask your doctor and health provider. Also, here is the main issue. Women think pregnancy finished, child born, I'm busy with baby feeding. No, it's not. Just go for postnatal care is more important. Discuss with your doctor, discuss your midwife, and just get some support, because it is more important for the woman to keep follow yourself with the postnatal care. Thank you. Any questions?
I have a question.
Yeah.
What are the big social media myths that you come across?
Big social media myth means
Wrong advice.
wrong advice, because the preeclampsia is hypertension in pregnancy, and the social media, they give the like some sort of sign or symptoms, but not exactly the same sign or symptoms, which is like really important to women know about the pregnancy. And also because we did some research on the vessels, the vessels get constrict, and this is the main cause because of the endothelium, the inner lining of the blood vessels. And we sometimes it's reversible in the lining, but they don't mention, the social media. And also, unfortunately, there is no awareness about the social media, in the social media, what's happening in exactly the blood vessels, why we are getting this hypertension. There is background of some diseases, some problems, the diabetes, overweight, and women, they don't care about during pregnancy. And even in our South Asian women, they think the eating oil, which is more important for pregnancy because baby can slip by itself. Unfortunately, there's this concept, but this is wrong concept. This is not happening. If they are eating more oil and taking more oil and fatty food and sugary food, is harmful. It's impacting their health and also baby health, because they making endothelium more stiff, I guess. Yeah, sorry, go on. If you want to ask any question about preeclampsia or baby's health or any help, I can say just take more help. Don't ignore your health. Yeah. Thank you. I'll just take out this. I don't know who is coming next.
Topic actually now, and I think in the media there's people like Davina McCall, who's a broadcaster who's really brought it into the fore as well, and even if you ask family members, they'll say, oh, I didn't know what was going on, but it was the menopause. And yeah, it's true. I was talking to a relative of mine and they were saying, yeah, this happened to my mother and we only realized after it was the menopause, what was going on. So I remember that conversation very clearly and distinctly, and that's made me more interested in the menopause and what it is. And I think there's so much out there. There's been so much information coming out in terms of HRT and what can be done about it. I'm guessing you're sticking to the female menopause, not the male one as well. But there's even talk about that. But there's so much research opportunity, so much to discuss. I really hope we have an interesting conversation. And it's not just important for women, but also the men who are also seeing women going through this as well. But I don't want to steal your thunder, Sarah. So over to you, Dr. Sarah Naeem. Just a warm round of applause, please.
I can, yeah. Hi, I'm Sarah, and I'm GPST3, and that means I'm in the final year, as you said, of my GP training. So I'm training in Northwich, so it's not here, I'm going far, I'm commuting, but you'll be seeing me here around soon, in a couple of months. So I chose this topic, it's my area of interest as well, because nobody talks about women's health in a way that it should be talked about. We have seen our mothers and aunts and grandmothers suffering with that, and nobody, especially where I grew up in those countries, it's not a thing to be talked about. And I think women have completely different bodies physiologically. Physiologically, we are very different from men, and we function very differently as well because of our hormones. We work in a cycle. Like we can't just do 9 to 5, 9 to 5. It's for men. Most of the things we see around these days, patterns or work jobs, things like that, all are meant to be for men, basically. It's not about women because we are not the same all around the month. We are very active, very bright, doing things, go, I'm doing this, I'm doing presentations, in the first half of your month, of your cycle. And then in the later half, you're like down, I'm not going anywhere, I'm resting, I'm sleeping, I'm not doing anything. So we are not meant, our bodies are not meant for this 9 to 5 things, and we are just doing it. So we just need to know more about our bodies, or we need to have more awareness of how physiologically we are different from the men, and how we should be advocating about the things to the GPs when we go, and how we need to talk about it. So perimenopause is something very less talked about out of all the talks we hear about women, because we hear about menopause, which is usually around the age of 51, but women who are from South Asian descent, it's around 46. It's not 51 even. So menopause is when the hormones are completely finished from the ovaries, like you don't get anything, your periods are stopped. But there is a good long time before menopause. Some people say it may be up to 12 years that you have all those reverse puberty. So like when you remember when you were in your teenage, I have teenagers in front of me. So when you were in your teenage, your hormones were sporadic. So like kind of everywhere, and not you are getting the proper ovulations and properly getting in every cycle. So it's happening again back with you. We're in that perimenopause state. So perimenopause is the time, and there can be from late 30s. I'm in my late 30s, and my husband says that you have started questioning a lot. And I think it's because of my hormones maybe getting down now. So I'm running low on them now, maybe. Because estrogen has receptors everywhere on your body, almost everywhere on your body. It's on your skin, it's on your brain, it's on your blood vessels. Estrogen has receptors on your livers, on your vagina, everywhere. Like everywhere you have the receptors. When estrogen binds with your skin, when you have a good amount of estrogen when you are in your youthful years, you are young, estrogen binds with your skin, you have elasticity, good elasticity of the skin, you have youthfulness. Then it binds with your liver receptors. It helps remove the bad cholesterol out of your body. When it binds with your brain receptors, you have more memory, good cognition. When it binds with your blood vessel receptors, you have good relaxed blood vessels. It even produces something called nitric oxide in your blood vessels that keep your blood vessels relaxed. That's why women at the same age as men tend to have less heart problems and vascular problems in younger ages. And their problems, all of them, I think, start from the going down of the hormones, from perimenopause stage, which we don't consider, which we don't think that this is something you need to work on. So typical age of onset, yet it says in the books it's 45, but it can be anything from your late 30s to 45, 46. If you go to a doctor when you are not 45 yet, they can still listen to your symptoms, and if your symptoms are bad enough to give you hormones or give you some support, they should, and we are giving them in the clinics. But we need to run a test for it usually at that point, which is called FSH, follicle stimulating hormone. I don't know if you are aware of that. So if you are more than 45, then blood tests are not recommended. But if you are less than 45, still you have to go through the hormonal tests, and they will find out if you are in real perimenopause or not. So 40 to 45 years age women, we usually do FSH. So FSH goes higher in women who have low estrogen. So your ovaries produce low estrogen. The brain signals the ovaries to make more. And that's why this hormone, follicle stimulating hormone, is higher. So when you have 40 to 45 years age, you have symptoms and they check your FSH, it can be higher if you are already in your perimenopause, because your ovaries are producing less estrogen, and now your brain is producing more follicle stimulating hormone to ask the ovaries to produce more follicles, more estrogen. So the FSH comes back very high, and we diagnose them as having perimenopause, and we can start the treatment if needed. So how do you recognize the signs of it? So there are very vague signs sometimes. Sometimes it's just that women come to us and they say, I feel like I have brain fog. I can't remember things. I have suddenly started having memory issues now. I was all okay before, and now I feel like I forget the names, I forget why I was gone to the kitchen or things like that. And even though they come and say, is it early stage of Alzheimer's maybe, doctor? like they can't think of it because it's brain fog. Because estrogen is not there in the connecting to the receptors now anymore. So they have this brain fog. Now the bad cholesterol starts accumulating because it's not going out. So they have increased bad cholesterol. And now their blood vessels are not that relaxed, so their blood pressures increase, so they have hypertensions now in perimenopause. So younger ages, women have comparatively no or very less chances of having hypertension, but as soon as they go into perimenopause or menopause, they are hypertensive. And when women are hypertensive, it's very difficult to control their hypertensions because we are different, as I told you. So we have a smaller diameter of the blood vessels as well. So we have a bit different physiologically everything from men. Cardiologists are here anyway. So one common symptom was brain fog. The other is hot flushes and night sweats. Very common when they come in and say. Third one may be vaginal dryness. They come and say, and we are having problems having sexual intercourse with the partner. we can't, I'm having a lot of pain. And sometimes even they come with bleeds and all because of the dryness. They don't know exactly. I had seen a 60-year-old woman a few days back, and she was having these all symptoms, and she didn't even know that she had some problem with, like, that she can get some help as well. And she was looking for, and I was like, how to go back to that age that I can help her with, like, because if we help them early, or if they seek help early, it's easier to control those symptoms, and it's more beneficial. So benefits are more than risks of treating the perimenopause if you come early to the doctor. So if you have these signs and symptoms, you need to go to your GP and discuss those signs and symptoms. So why are we going to track our cycles? So as soon as you feel like there is some shift in my cycles now, it's not the same as it was before. It's becoming more frequent or less frequent, most likely. Less frequent, or having very small bleeds every time. So there are many women who come in and say, I'm having very light bleeds now, and like my periods are coming after 2 months or 3 months, and they are coming very irregular. Sometimes they do come with menorrhagia, which means like more bleeds or more intervals of bleeds. So it's good if you can make a small note how your periods are going for 3 to 4 months, at least make a diary before going to your GP. So there should be a few things that you need to work on before going to your doctor, so that at least you can tell them a bit more clear that this is what is going on. And because they have only 10 minutes, now I know how to, deal with everything in just those 10 minutes is so hard. So if you have worked up a little bit already before going to your GP, and you just say, I have this and this and this, top 3-4 symptoms that you are already noting down, so that it's easier for them to discuss it with you and help you accordingly. So, yeah, that is it. We were talking about preparing for GP appointment, note top 3 symptoms, record period changes or diary. Your medication and family history matters as well, because HRT, if the doctor is thinking to give you, or you have made a shared decision with doctor to talk about like hormone replacement therapy, it's very important for the doctor to know about your family history and your own medical history as well, because it's contraindicated or it is not given if you have current breast cancer or there is a history of breast cancers in your family, especially those estrogen receptor sensitive breast cancers. Yeah, discuss the options with your GP and yes, follow up. Okay, so the management is not only hormonal replacement therapy. So our lifestyle matters a lot. So we are encouraging women to, just as everybody said today, go and have 7 to 10,000 at least steps every day, walk around, have light clothes if it is the hot flushes that are bothering you. And if you are taking alcohol, then reduce the amount of alcohol, because alcohol can also directly cause cancers as well. So how do we do the risk assessment in people who come for HRT, hormone replacement therapy? So we see that if they have breast cancer current now, or if there is a history in their families of having breast cancers, if they have a history of blood clots or any bleeding or clotting disorders, so they can be anything from DVT in the past, while after delivery some women go through and they can have the DVT. So if there is a history of DVT or blood clots in the past, we can still give them HRT, but then we have to discuss different options of it. So usually transdermal ones, the gels and the patches that we give them to use on the skin are then more appropriate, rather oral ones. And if heart disease is there as well, we need to talk about, because there is very small risk, but yes, there is a risk of heart disease with HRT. You know, it's very new that FDA, American, they have actually removed all the black label warnings from HRT, which were once something very horrible, and people used to be like, it is something black labeled. And so they have removed it, and hopefully MHRA will do it the same soon, but it's not here yet.
I'm so sorry, but I'm not very well, so I had to go.
Yeah, you can. Carry on, everybody's tired. Don't worry. So hot flushes, you can help yourself as well by just avoiding the triggers like spicy foods, alcohol, sometimes having caffeine, stopping smoking, good sleep routine, regular exercise. This is something we tell all of them. But it has a certain degree of effect on their perimenopausal symptoms, to be honest. Yes, so what is the best time to start HRT? That's why I'm talking about perimenopause, because it is now quite evident, so we have good evidence about it, that if we start HRT earlier, like in your perimenopause, within 10 years of your menopause at least, before the age of 60, you may say, it has benefits more than the risks. And it is most effective in this period of time, in your perimenopause, because 50 years is the age where most women present with fragility fractures. So 50 is the age where most women will present with fragility fractures, which means the fracture that you can get with a very a small blow, or very unlikely to have fracture, but you got it because your bones were getting estrogen, which is not there now. So your bones are slightly reducing their density. So your density is reduced, and most women start getting the fractures around that time. To prevent all that, along with all the symptoms that you are having, of course the treatment for that symptoms as well, but I think the important part is your bone density, your memory issues, and the other things are like, the cholesterol and hypertensions and all. So I think it's very good to start, and there's a good evidence for that as well, to start HRT if you plan with your doctor to start it within this perimenopause age, at least before you are 60. What is HRT? Yes, so hormone replacement therapy simply tops up the hormones your body is struggling to. So it's not all artificial. There are myths. There are myths about, and there were artificial hormones before, and some of them are still we are using, and we are prescribing, where we don't have any other, what I should say, we can't go any other way. So we do prescribe them still. So there are estrogens and progesterones now, which are called bioidentical. Bioidentical means they are derived from yam, and they are more physiologically closer to your body hormones. So they are not synthetic ones. So synthetic ones were in the past, and most of them you still take by mouth. And these ones, which are usually given these days, these are the ones that you use on the skin, estrogens, estradiols, and then you are given the micronized progesterones, which are bioidentical progesterones and safer progesterones compared to the older versions, which were synthetic ones. And these are given by mouth along with estrogens to protect your endometrium of the uterus. again, it's the types of HRT. So transdermal are the new ones that I'm talking about: patches, gels, sprays. Then it's oral, convenient but carries risk of blood clot. So when you use the transdermal ones like patches, gels, sprays, it bypasses the liver then, and so because your liver produces those clotting factors, so it bypasses the liver and it's just on going straight to your blood from the skin, and so you don't have those clotting risk. So you don't have the blood clot risk with transdermal ones. Absolutely not. There's nothing about it that we have. Oral ones, yes, it's still there. Clotting risk, small risk is there. Small breast cancer risk is there, but it's not more than what you can have with 2 glasses of wine a day, or being overweight, or it's a very small risk, like 7 to 14 women in 1,000, I think, is increased risk of breast cancers with oral ones, isn't it? Around. Okay, and vaginal one. Okay, vaginal one I think is the best thing that they have discovered or made so far, because vaginal estrogens that are given is most likely we give estriol. It's a very weak one, and it can be given even to a bit younger women as well. Like, it has nothing to do much with your going into your bloodstream, and also if you have vaginal dryness, go talk to your GP. They should straight away prescribe it to you, because there are not many contraindications to that as well. So it should be given to the women who have these problems, especially the dryness, and if they are even not in the perimenopause age, and if they are having dryness because of other reasons, like they are breastfeeding, or because of many other reasons women can have the vaginal dryness, you can be prescribed vaginal estrogen. And it's so good for really, because because this is something that women don't know it's a part of perimenopause or menopause. They don't even know when they come to us. So benefits and risks, yes, I think we talked about protects against osteoporosis, which I talked about the bones thing, and it reduces the risk of heart disease. It improves mood and sleep quality, yes. So progesterones are so good for sleep. I have seen people telling me just after like 12 weeks or so starting HRT, telling, oh doctor, my sleep improved so good. I'm sleeping so good after that, because at night time the progesterone is advised to take at night time. So estrogen usually we advise to use in the morning on the arms or legs, and the progesterone we advise them to take before sleep by mouth micronized if you are taking. So progesterone helps them with the sleep, and we have other things as well, like non-hormonal things which help them with sleep and mood swings and these hot flushes. Like I do say to them, like, you can take magnesium glycinate before sleeping. It's so good. It's really good, and there is evidence for magnesium glycinate to take before sleeping. It helps with the sleep. Yes, there is a small risk of breast cancer, which I told you about, like 14 out of 1,000 people. Risk is low. For most women, the risk is less than that drinking 2 glasses of wine a night or being overweight. So you still, and there are many other reasons for breast cancers as well, like not having children or not breastfeeding. Just like I said, alcohol, if you have been drinking 2 standard drinks every day. There are many other reasons for having breast cancer, to be honest. So even just when you go to menopause, all of a sudden your risk of having breast cancer automatically increases, because the breast cells, they start like quite aware of dying, very older, and then your ovaries start producing more of the estrogen. And okay, yeah, we talked about already. HRT initiated before the age of 60 or within 10 years of menopause likely to be associated with a reduction in heart disease and cardiovascular mortality subsequently. Reduction in osteoporosis, I think this is one of the biggest thing I would say women should know, that your bones density is reducing and you need to work on it. Take your vitamin D, and I would advise D3K2. Some people do not take it, but I think it's good because it does not let the calcium to be deposited in your blood vessels. So D3K2, and yes, for preventing your bones to go osteoporosis, you need to work on HRT as well, maybe for short interval. Okay, the last things, take-home messages. If it is not adding up, think perimenopause, please, please, please. If you think you are in your late 30s or early 40s, even 40s, any 40s, and you have all these things what I was talking about, brain fog, mood swings, hot flushes, night sweats, your bones pain, you need to go and get it checked. You may be in your perimenopause and you may need help. Go and take it before you go to your GP at your age of 60, as I told you about of the woman I saw. So 60 was like, I wasn't sure even I should be starting now at this point to her at the HRT. Talk to your GP, we will listen to you, discuss management plans. So it's always a shared decision, it's never from us only. So we always discuss the risks, the potential risks with HRT with you all, and we do discuss how is it beneficial for you. So we can weigh the benefits and the risk, and always the benefits are more than risks if you start it earlier in your perimenopause, like before the age of 60 or within the 10 years of menopause. So, okay, thank you. Any questions? Any questions? No questions? Okay. Thank you.
Official, we are not there just to flog you some specs. I promise you that bit. Okay, the second bit is cataracts. So obviously cataracts is a clouding of the eye's lens. It is most commonly associated with aging. It can be caused by certain medications. Steroids, for example, can increase the risk of cataract. So again, it's very important if you are taking any medication, it's always good to have a regular eye test. Dry eye syndrome is a condition where the eyes obviously don't produce enough tears. It can be managed quite easily at home by practice. You require drops usually, and obviously it's still important for you to have a chat with optometrists. Glaucoma is a group of conditions. It's commonly defined as an increased ocular pressure which causes some damage to the optic nerve. It's very important in glaucoma that you are having regular eye appointments. Obviously, you can be referred to the hospital. It depends on your optometrist. There are new technologies, for example, OCT scans, which are available. It's a bit like doing an MRI of the eye, which will show damage a lot quicker than other tests. So it's important that you ask your optometrist for those sorts of things. And then we have AMD, which finally is a condition affecting over 500,000 people in the UK. It does cause serious gaps in central vision. So if you feel you're getting a little bit older, you're starting to struggle to see up close for reading, you could have any one of these conditions. You could have multiple at the same time. It is possible that you can have glaucoma and cataracts together. So it is important that you book an eye test. Okay? The next slide is on myths about cataracts. Just very quickly before I click on and you get all the answers, does anybody have any myths about cataracts that they want to ask about or that they know about? No? Okay. So, some of the myths about cataracts. Obviously, these are just 10 that we thought of at the time when we put this together. I'm only going to cover a few of them. The main one, first of all, from my perspective, is quite often patients are saying that they don't want to be referred for surgery because the surgery is painful. I can honestly say it is not painful. I have tried it in a dry lab myself, not on a real person. It's incredibly tricky to do, So I appreciate if there are any ophthalmologists in the room, my hat goes out to you. It's very, very common. It takes less time to do a cataract surgery than it takes to make a cup of tea. And I promise you, because we've tried it. We've physically timed it. The second one is the recovery time is quite long. It typically is not that long. Usually you have a patch over the eye for the first 48 hours to make sure that there's nothing going into the eye. After that, you're on some drops for 2 to 4 weeks, and then you are all done. That's it. There is no further treatment required. So having cataract surgery is quite simple. The recovery time is not a lot. To operate, they must be ripe. So this is another thing. Once upon a time, when patients were referred for surgery, you were always being referred based on your vision or based on an impact for driving. That is no longer the case. The NHS ruling has changed. There are multiple reasons. There are multiple ways in which you can get referred. There are multiple reasons why you can get referred. So it is always important to have that conversation with your optometrist. And then the final one I want to touch on is that they are very difficult to remove. They are not very difficult to remove. The operation is done under a local anesthetic. There are multiple service providers now available in the Northwest area. I assume everybody is from the Northwest area. So there are multiple service providers. Obviously, have a conversation with your local optometrist, and hopefully they will be able to refer you to the right people. And then finally, just a few things about maintaining good eye health. So regular eye examinations is key. I'm not saying that just from a business perspective. It is genuinely the case to have regular eye examinations. There are a lot of things we can pick up. For example, diabetes, blood pressure, just to name two. There are multiple other conditions we can pick up as well. And then particularly for the youngsters in the room, which I appreciate, there's only the young lady at the back, limiting screen time. So if you're on your phone or your iPad or your laptop or any other electronic device, it is very, very important that you limit the amount of time that you are spending on it. The science does say the longer you spend on a phone or a laptop or an iPad, especially at a younger age, the worse your prescription will get. So it's important. Myopia is a massive pandemic at the moment, and it's very, very important that you are limiting the amount of time that you spend on screens. And then finally, obviously, avoid rubbing your eyes and limit the amount of exposure you get to the sun. So again, make sure that you're putting on some sunglasses. Make sure you're protecting the eyes as much as you can. Is that okay? I appreciate the lads are making a slight bit of noise. Finally, are there any questions? Doctors at the back, am I safe? No questions? Thank you very much. It was short and sweet. We'll go on to the next one.
It is very important, as Fahim has mentioned. We were just in US a few months back, and there was a guy who has done a global study on IBS, and he found that 1 in 3 population all over the world has got some kind of GI issues. So it's more than 2 billion people have got some kind of GI or liver issues going on. So as Fahim mentioned, it is very, very common, very, very important, and most importantly, quite safe and quite easily treatable. Who I am, why you guys should be waiting for me, listening to me, what probably, is it something probably that I'm just making it up? Well, probably sadly not. So this is me, probably, my qualifications, I'm a gastroenterology and hepatology consultant, working currently in Lancaster Infirmary, specialist in gut and liver health. I've got focus, special interest in advanced endoscopy, hepatobiliary, digestive wellness, IBS. I'm a founder of GABA Plus Community Gastro Initiative. Just been for a year or so been founded Genius, which is a gastroenterology network around the region for innovation, understanding, and sciences. I've designed gastro teaching program, which has been, by the way, so it's very nice. Probably I think we should catch up with that. That's a gastro 360 teaching program we have just developed, which has been now attended by it's more than 50 sessions we have done, and attended by more than 500 healthcare professionals. And we are launching soon these GABA Plus digestive health clinics as well, hopefully soon. What my aim is, just very quickly, to simplify what IBS, what is IBS, what it means for you guys, and what you need to take. Very quick few messages from this evening. Just clarity, confidence, calm, nothing to worry about. For this talk, I don't have any disclosures. What is IBS? I don't know, probably how, obviously, because of the constraint of time, I wanted to make it interactive, obviously, but a lot of myths about IBS is that it's some kind of a pathological process or something. So the main thing is that it is safe, it does not cause cancer, and it is easily manageable. The caveat is that this is kind of a interaction between your brain and gut, which basically means is that if one thing is going to go wrong, the other is going to go wrong as well. What it means is that it can be sorted if probably we do the right things. There is no inflammation, there is no cancer risk. There is a simple thing is that a miscommunication between your gut and brain. Its symptoms comes in waves, intermittent. The main symptoms, everybody will have some of these. I probably promise. If you're saying you don't have them, you're lying. Okay. It's pain, bloating, and bowel changes. What I say that when I talk to my patients in the clinic is that it's IBS is like a smoke alarm which goes off when someone makes a toast. So whatever is going to something happen is going to just trigger it. Why it happens that why we are worried about it? That is, I think it happens. Let's start from why we are worried about it, because it is troublesome. I have seen people, these symptoms have debilitated them. They can't go to work, they can't do anything, their quality of life is horrible, and they will be in pain with hot water bottles, and they think that. And the main reason why it happens is that only threefold. I have tried to make it as simple as possible for you guys. This is what you need to know. The topmost triggering factor is stress and anxiety. Next is irregular eating and skipping meals. And the third thing is that caffeine, fizzy drinks, and processed foods. Now, the main point, as you can see, is that if you calm these triggers, you will calm the gut. If you calm these triggers, you will calm the gut. How do we do that? 5 simple steps to a calmer gut. Very quick, easy, nice. So regular meals. So the main thing is that your brain works in connection with your gut. When we are all over the place, our dietary habits are all over the place, our routine is all over the place, the brain is going to keep signaling to the gut that something is not right. And what it does is that it, and not going into too much detail, it triggers your symptoms because it's increased the receptors which causes these symptoms in your gut lining. Not going into much detail about that. So regular meals. You tell your gut that everything is calmed down. Whatever you are feeling, you tell your gut. Normal, regular meals. And then your gut will start sensing it few days that there's nothing is wrong. Yeah? Reduce bloating feed. So there is a lot of discussion, lot of evidence for low FODMAP diet. I have not put it in just because I didn't want to go into those details, because without supervision of dietitians, without a proper healthcare professional involved, the chances of them involving low FODMAP diet or into that can get you dehydrated very quickly and nutritionally depleted. So what I've said is that for our routine thing, reduce foods which can get you bloated. Among them, the main 5 foods are onion, garlic, beans, fizzy drinks, artificial sweeteners. If you do these avoid these for few. Now, when I say avoid them, when I discuss this with patients, how I say them is that do not take them for 4 to 6 weeks and then slowly introduce them one at a time. What it will do is that few of those foods you will find out by doing that which triggers your symptoms. Now you need to avoid them and your symptoms will start getting better. Limit caffeine. This is one of the most important things. All of working professionals, we drink a lot of it. Yeah. After 12 p.m., try not to have that after 12 p.m. And then obviously some of your symptoms will get better. Gentle fibers, oat and psyllium, that is basically husk. Just take that slow at a time. Oats in the morning, husk at night time, 1 tablespoon to start with, slowly build it up. Your bloating, your constipation, your gut health will going to improve it. There's nothing like it. There's nothing like organic and natural things. The important thing is, which is very important, which is not here, is that the things which we think are healthy, they are very healthy, but not good for IBS. For example, that is very important because we don't know that. For us, brown bread is healthy. It's always healthy. Less sugar is healthy. Artificial sweeteners is healthy. Coke Zero is healthy. For IBS, all of this is not healthy.
What about sourdough?
Yeah, it's not. We say white bread for IBS. That is very tricky. The problem is that is wheat bran. Now the wheat bran gets it produces excess amount of fermentable gas, you see. That was going to worsen your bloating. Now, what do you need to do? You need to tell the gut that everything is calm, relax, with a white bread for a few weeks, and then slowly reintroduce it over the period of next few weeks. That is important because we don't know that. That's opposite to the general health. So if you have got general health, you want general healthy lifestyle, but if your IBS is really making you doing problems for you, then your diet needs to be adjusted by somebody who knows what you are doing. Yeah? Okay, calm the gut, brain loop, breathing, walking, sleep, comfortable, healthy life routine. When to seek medical advice. I think that this is very important because you can't manage everything on your own, isn't it? It's good that probably you've got Fahim to give him a call or something every now and then. But probably, not probably. You need somebody who knows what they are doing, isn't it? Yeah. Not Fahim can sort out 95% of the things, but the rest of 5 of the things probably you need somebody, isn't it? So if you have got unintentional weight loss, rectal bleeding, new symptoms after 50, he's going to send. If he sees any of these, he's going to send to us anyway. But probably if you've got anything, first go and see him. He is your man because he is going to sort you guys out. IBS does not cause cancer. Just reassuring. If probably one message for tonight, it's that it is treatable. It does not cause cancer. Nothing to worry about. You just need sorting your gut out. All right, this is gone.
Is there like any overlap with prostate cancer or prostate cancer symptoms and IBS symptoms? Is there any overlap there? Or
Every tummy issue, there are multiple organs in there. Mm-hmm. The main reaction to body for all of the problems are pain. Yeah. Now that is exactly where the healthcare professionals need to point out where the pain is, what type of pain it is, what it is related to. Obviously, when probably when you guys see your GP, obviously Fahim is there, and obviously my wife, and I think my colleagues are there as well. When you see them, probably these are the guys who are going to tell them what that pain is related with, associated symptoms. That's a general feel of the medical college thing anyway. And then obviously they direct you that. Prostrates mean, do they have any urinary symptoms? Now problem is that in IBS you will have something else. So IBS, again, I didn't go into those details, didn't want to intentionally. There is a Rome 4 diagnostic criteria internationally accepted by which diagnose IBS, you see. And to diagnose IBS, you should have continuous, persistent, daily abdominal pain, 5 days out of 7, around 6 months or longer, which is related to your defecation. Then you fit the criteria of Rome criteria, which is diagnosis of IBS. So it might not be IBS. So prostate cancer, any cause of obviously abdominal pain needs to be explored properly. That is why, if you're not sure, call your doctor. Yeah? I probably just a reminder before obviously you guys go. Just a quick. When stress goes high, the tummy will cry. Yeah? Slow down a bit, let the gut sigh. Eat on time, keep caffeine low. Small steady habits help the symptoms go. Yeah? Just a little bit of message. Watch the space. We are bringing a lot of these community projects just to keep you guys busy, yeah, and keep us as busy as well. I'm developing GABA Plus. It's a long-term community gastro. Obviously, Fahim knows a lot of it, and then I think we'll be doing some projects together as well. It's health education programs, self-care resources, monthly gut wellness tips, community workshops, and all these kind of. So just watch this space, and if anybody have got any concerns, anybody wants to ask anything, you can always email me or get in touch with social media or something. It's easy. My name is Waqas Kaba and the email is dr.myfullname@gmail.com. You can email me. I'll try to help or at least guide you whatever I can. That's quick, easy. Anything else? Thank you very much. Any other questions, you guys?
I'm going to take some questions on IBS. Do you have any questions? Yeah. Quick question. You mentioned a link to defecation. What's the link between the symptom?
So the link with defecation and IBS.
It's not here. So to diagnose IBS, international consensus in the guidelines all over the world has come up with a criteria. They call it Rome criteria because it was done in Rome. It's the Rome 4 criteria says that to diagnose IBS, you need to have a pain every day, most of your week, for more than 6 months, and the pain should be related to defecation. Either it should come with defecation or get relieved with defecation. And then that is the kind of IBS. Nobody in the world diagnoses IBS with this. Almost everybody will have some kind of investigations done, whether that is non-invasive or invasive. But this is something which gives you a little bit of kind of first step to work with. Okay, all right. Is there a vouchers or something?
The tea's finished now, vouchers. You got a hand up there. Is that Eunice? You want to ask about IBS? Yeah. Mr. Khan, one of the co-organisers for today.
Thank you. Just one of the, and with Fahim's, Fahim's packed agenda, as we all know. Yeah. One of the treatments people are given usually is creams when they get IBS. Steroid cream and things like, if they have, it affects the hair around the head and arms and things. So is it useful to use the creams, or is it, just for treatment?
Which creams? There's no steroid cream used for IBS treatment. Must be something different they're using.
Yeah, I know my daughter had IBS, and she was given some creams just as sort of a treatment.
For the symptoms.
It's for the symptoms, yeah.
Oh, you mean IBD?
Well, she said she was diagnosed.
There's no cream for that.
Yeah.
There has to be either suppositories or there is enemas or tablet steroids.
Yeah.
There's
no cream. Yeah.
There is no role of steroids in IBS.
Yeah.
There are some symptoms which overlap between IBS and IBD.
Yeah.
But that is exactly where probably a doctor comes, and obviously you need to see a specialist gastroenterologist.
Yeah.
And they need to obviously treat the IBD.
So what is IBD? Sorry, can I?
Inflammatory bowel disease.
Okay.
Ulcerative colitis and Crohn's disease. That is different from IBS. Yeah. Sorry. Okay. So so there is no role of steroids, any form of cream, ointment, enemas, suppositories. All of these steroids comes in all of these shapes and sizes. Yeah. We always give them, but we give them from inflammatory bowel disease. There is no treatment role or evidence of suggesting that there is any cream or anything which should be given or should not be given. If somebody has given them, ask for him to probably check on them. For him, you need to check somebody who has given cream for steroids.
I want to ask you a question.
Yeah.
Can I ask you a question?
Go on, yes.
So what about things like probiotics? That's the one that people talk about a lot. They're very popular now in the supermarkets. And if people come to us and say, can you cure IBS? Are we just managing it like chronic eczema, or are we actually doing something curative?
Good question. So IBS is more behavioral and lifestyle management rather than curing. We're not curing anything because there is no pathology which you go and take the cancer out or something. What it is that it is a hypersensitive gut because of DGBI, disorder of gut-brain interaction basically. So what we are doing is that we are making their life easy by symptom control. To be fair, IBD is the same as well. You can't treat IBD. I can't treat IBD. This is the first thing I say to my complex clinic, because I do a complex clinic in my hospital where I say that I cannot treat you. Nobody can cure you. I can get your life much better and back to baseline as much as I can, you see. That's probably what I say to them. Now, coming back to your question, probiotics. Excellent question. We do not have a documented evidence or randomized control trial or a proper research suggesting it is beneficial. But saying that, there is a lot of people who get a lot of benefit for that. It's probably my experience of seeing thousands of these patients is that you try prebiotic or probiotic for 4 weeks, whatever you like, whichever company you like, I don't mind. If it benefits you, continue. If it does not, stop it. Simple.
Oh, that's scientific. I like that. Yeah. So trying something for 4 weeks and then seeing if it works. Yeah, I'm happy with that. I think that's really good advice. Something I can take away as well there. Any further questions on IBS from anyone at the audience? Yes, Abdul Latif. Yes, please.
Yeah. What are your thoughts on like intermittent fasting or something like that? Would that like help or hinder like somebody with IBS?
Yeah, the concept of fasting, obviously, intermittent fasting. How does that help the GBI?
Well, I think there is no evidence on that. I don't think there is so when I say evidence, I mean hard evidence, not a case. I think there are observational studies. They are on online probably. You can search PubMed and they'll have observational studies. Yeah. I don't consider them worthwhile to document and say on any forum. Saying that again, some people, if they calm their gut, they do not eat for intermittent, do intermittent fasting, or especially in the fasting, some people come back and then say that after Ramadan that their gut is better or something. For that side of thing, it obviously is helpful, but there is no RCTs or any kind of meta-analysis done to compare those things that whether that is good or not. Theoretically speaking, hypothetically speaking, probably it should help. If obviously you are getting less trigger to the gut, its symptoms should calm down. But again, nobody has done, and I don't think you'll get an ethical approval for this research anyway, that you're going to put some people through intermittent fasting and not to put them and then compare their symptoms. I don't think that you can get that research and it will be ethically proven, and we can't prove them basically. But if it's helping you, carry on. On that note, sorry? Yeah, exactly. So I think what happens that probably, so for example, celiac disease, probably it's a gluten hypersensitivity, isn't it? Now, 1/3 of the population have gluten hypersensitivity. Just to let you guys know, and I think these are GPs here as well, you see, they do not have celiac, but they behave like celiac because they've got gluten intolerance. Now, the trouble is that, should we give them gluten or not? We should not give them gluten. We should not get their symptoms worse. No harm first, isn't it? So ask them, you are not gluten, you have got gluten intolerance, but you do not take gluten because that's worse in your symptoms.
Just on that, how do you know that, because obviously when we do the test for it, with the antibodies, it just comes positive and negative. So how would I know someone's just got that?
Have you done the D2 biopsies?
No, we don't do the biopsies. But they wouldn't qualify for a biopsy because it's negative.
No, they would, because their symptoms obviously we're going to make them. They'll be losing weight, they will have abdominal bloating and all those things. So that will going to put you on that STD pathway, and then you can send them all those. Or when you send them to the secondary care, they'll do that gastroscopy with D2 biopsies, because the first thing these patients will say is that they have, so the FODMAP whole concept, you are doing exclusion and reintroduction, they have done that for you. They know which food triggers their symptom. You get their D2 biopsies. If that is negative, you say them, you have got gluten intolerance, stop taking gluten and your symptoms will be better, though you are not diagnosed celiac.
Okay, that's interesting. Yes, people are now really asking a lot of questions now. Yes, go ahead.
Right, so I just need to ask that because for the FODMAP diet, we have to refer to dietitian. So is there anyone in the community, or you're going to develop a community service? Because it's really hard to refer patients, especially for the FODMAP diet, we have to involve the dietitian. And especially for guests, there are no dietitian in the community. So how far is that?
I think it's a very good question and a very good practical next step forward to see, because the problem is that we don't have enough resources to have a gastro-specific dietitian or community services. Now, it obviously depends that how symptomatic the patients are there. If we think that, or how sensible they are, let's put it that way. If they are sensible enough, that I can send you obviously a link, or other guys a link. There is a MASH University who are the gold standard pioneer in this low-fat MAP diet. They have got an excellent resources online where patients, if they are sensible enough, they are young, they are healthy. So if you think they will, so first thing obviously, not saying that, but obviously if they can manage private services, that's the way to go. The private dietitian or nutrition. If they can't manage them, then they are sensible enough, then they should look into that March Society and then see there are online resources into that. The reason I don't like it, and people, it's obviously, the gastroenterologists have got different views into that, whether they should start load for, there are a lot of colleagues where I work, they put in the letter that, give a trial of low FODMAP diet and see how it goes. I do not like that I'm just probably discharging people into the primary care with this advice, because what my worry is that they are going to get dehydrated or nutritionally depleted, because have you seen the list of low FODMAP? It is crazy. It's 16 things out of probably you can't eat anything until you have got a little bit better dietitians involved in that. Now, the ways to navigate that is that either you, obviously they take advice from private dietitians if they don't have services. Secondly, if they're sensible enough to look into that March Society website and do that by step. There is stepwise approach. You take these 4 things out, you reintroduce them. Then you take next 4 things out of your diet, then reintroduce them, and then figure out that which of these trigger your symptoms, and then you take it from there. The third thing is that, yes, coming back to the second part of your question, yes, this is the plan of us, that we are planning, hopefully that we'll have a one-stop shop in the community for hepatology as well as gastro. For hepatology, whoever will have deranged liver function test or fatty liver or all those things, obviously, they will see one of us, they'll have a fibroscan done, and we'll discharge them from this same day. No 1 year wait. Currently, the people have to wait for 2 years to see me, which is crazy. Which is absolutely crazy. And on a gastro side of things as well, That's the plan, is that they probably, I think if they need an endoscopy, they'll have a TNE, which is without sedation, transnasal endoscopy on the same sitting. If they need, there will be a dietitian in the community present in the room to give them advice and discharge or follow them up. Excellent. Anything else?
Yeah. I have a question and probably observations around fasting, especially during Ramadan. So the first question is how much of an impact does that have on IBS?
Yeah.
And secondly, is there an opportunity here to do some kind of observational study on the impact of fasting on IBS?
Yeah.
Looking at populations in the southern hemisphere where you'll have people fasting for 20 hours and people in the northern hemisphere is fasting for 6 hours, 12 hours.
I mean, I think observational studies have already been done. As I was mentioning previously, they are already been done. The problem is that observational studies have got there is a huge bias, isn't it? There's a huge research bias in that will not going to. It's okay to give you confidence. I already have got confidence in those research, but it's not going to change the practice worldwide, you see. To change the practice worldwide, to put that into a proper guidelines so that everybody, every gastroenterologist in the world can follow, you need more than observational studies. For example, probiotics. There's a lot of observational studies. Some of them are weak cohorts, comparative studies analysis as well on probiotics, which are excellent. The problem is that because there is no randomized controlled trial, meta-analysis or something of that level, you cannot say that, okay, a low FODMAP has, there is an excellent evidence at every level regarding low FODMAP value. You see, that is the issue here, is that observational studies give you an idea, give you that, okay, this is what we are working on.
Yep.
You cannot make them guidelines which can be followed as a standard throughout the world. For that you need better evidence. And when you say better evidence, I mean, if you start, I don't know probably how much you've got a background of research, if you look at that, we're talking about systemic review meta-analysis, then randomized controlled trials, then you come into that, obviously, the comparative analysis, and then you come to and observation studies are right at the second last, and then after that you've got individual cases.
Okay, all right.
So evidence-wise, you need to have something better there. And the next question obviously would be that you would need a lot of volunteers, isn't it? Because ethically, how are you going to kind of get the approval for something like that? Saying that obviously you are, so you need fasting volunteers who are going to tell you probably we are happy in those hemispheres, because you can't pay somebody to kind of do that, or volunteers, isn't it?
You've got, well, within the Muslim community, potentially you've got willing fasting.
Volunteers, isn't it?
Yeah,
exactly.
yeah.
That's exactly it. Is that probably is something that which probably it will be voluntary study rather than again difficult to get ethical approval for that.
Great. I had another question, Wakas, if you don't mind. Any new exciting research or developments in IBS that you think people should know about?
Loads of things. I think they are trying to do that. I think they are trying to see if fecal microbial transplants and FMTs can work into that as well, because FMT has worked excellently in the recurrence of and refractory C. diff. We are doing that. So I think what they're doing is that changing that might help as well. I don't think that's going to help, but let's see. And I think the other thing is that you might have heard about those, something which really helps is that, so it's good you have mentioned that, is these gut hypnotherapies, you see. There is, I'll send you the link, that will be helpful for you guys, you see. There is an app which gives you, I think, certain hours without paying a free gut hypnotherapy. And some people probably will utilize that in IBS have really probably are saying that they're helping. And if it's helping, then obviously they can pay that as well. But first few sessions are free of cost to see if that helps. Gut hypnotherapy is a good thing.
Right. That's really interesting. Anyone else, any further questions? I think we've really exhausted it on IBS. It's a really interesting topic. I want to thank Dr. Wakas Gaba again. Please, a round of applause.